Hi everyone. I'm William Fortin, vascular surgeon here at Sacré-Cœur, like Asher said, and I'm going to present on the endovascular component of the aortic treatment. It's a pleasure to be here today. It's a pleasure to meet you all. We've been working a lot, the vascular and the cardiac surgeons together, so it's always good to communicate and to share expertises wherever needed. Um, Before we start, I'm a consultant for Medtronic and Gore, so it's to keep in mind because we're going to talk a lot about grafts and endografts and all these things. So keep that in mind. Asher asked me to go through quite a program today. So the main objectives are here. I decided to go for a plan that would englobe pretty much everything that is in these objectives, but we'll go in six different main points, and then we'll go further in every one of them and try to make sense of all of what's happened in the endovascular aortic domain in the past decades. So it's a lot to cover. Please don't hesitate at the end if you have questions. There's going to be dense um, slides in there. I'm sorry for that. I just wanted to, of course, this is going to be an overview, but I wanted to for you to have as much of a complete overview of all of these different treatments and the options that you could have in the future whenever you get in front of these pathologies and you don't really know if you should do endo, open, hybrid. So we'll start with the introduction of the aortic endovascular history. Then we'll go through the indications of treatment, the case preparation, perioperative consideration, the outcomes, and then we'll follow up with the surveillance. So endovascular surgery for the aorta specifically started in the 70s and then in the 80s. Nikolai Volodos in Ukraine was the first one to describe. Basically, he used a polyester graft. He put some Z stents in it in metal, and he implanted it in dogs and then in humans. So he's the first one to have described this technique. That is going to be called in the future stent grafting. Then ensued, as most of the science did in these years, some kind of a competition, mostly in between Ukraine at first, and then the west of Russia, and then Europe in between this part of the world and North America at first. In the 90s, then Juan Parodi in Argentina at that time moved to the US and combined his expertise with Julio Palma's expertise to build the first aortounilia graft and treated the first patients in the 90s with tubular polyester grafts combined with the Palma stent in the proximal part of it to seal and the distal part too. Then it boomed everywhere in the US, in Europe's and in Australia. We got to a point where Tim Tudors in the 90s too in the US started doing some bifurcated grafts too, with the first experience being described in 1993. At this point in Australia and Seoul in South Korea, there's the first reports of the first fenestrated grafts too that appeared around 1996. At that point, the industry started to get involved and started to have some grafts that got approved by the FDA, by some in Canada, and by the Europeans guidelines too. Cook was the first one to pioneer the grafts with the bifurcated Zenith graft and then the Zenith Alpha for the thoracic part, and then Boston Scientific arrived with their Anchor graft. Medtronic arrived with the Aneurysms that was replaced in the 2000s by the Endurant and the Talent in the thoracic segment. And Gore arrived with their product a bit later with the Excluder in 2002 and the Tag in 2005 for the thoracic segment. Many more followed in the future, of course, as you may know. The industry and the scientific community started to basically burgeon everywhere in the world in the early 2000s with graphs with directional branches that appeared on the market, and then we had multi-branch systems that appeared 2000 and up, pioneered by Tim Tudor in the US and Roy Greenberg in the US too. Fantastic vascular surgeon that had a lot of trainees after that that went and continued his amazing work. At this point, the physician modified graphs started to arrive, and the first description of them started to be published. And Cook went on and built the first CMDs after that, based on the experience of Roy Greenberg and his fellows, specifically Stéphane Roland in France, Tara Mastracci that practiced in Canada, and then in the UK, and Gustavo Aldrich, who's an Argentinian that installed himself in the US after that. In the 2000s, our rock star in vascular surgery, Cherry Abraham from Montreal, Canada, at the McGill University, also published the first case of implementation in a human of endo-branched arch graft in 2009, and followed a series published by the usual suspects, so Roy Greenberg and his team, and Tim Tudor in 2014, about the first arch grafts in a series. And today now, that's the kind of outlook of what kind of graphs we can have. So there's the first reports in the past few years of endo-arch combined with the ascending grafts, which has been commonly called endo-bentol. There's PMEGs of the arch. There's also endo-arch grafts that are CMDs. There's the unibranch grafts. We have candy plugs and other dissection treatments, and thoracoabdominal stents that we could use either for the arch, the thoracoabdominal aorta, and the branches in the iliacs. So what are the indication for treatment for the endovascular surgery, and a bit of combination with the comparison with the open surgery? In general, things that make sense, of course, endo treatment is minimally invasive. It usually encompasses shorter hospital stay, less initial morbidity. Although it's usually less durable, we're working on it as much as we can, and it does not cure infection specifically. So it can serve as a bridge if we want to make sure that the patient gets healthier, or sometimes in sicker patients, we could think about a definitive treatment with coverage. But of course, the graft is going to be considered infected for life. It necessitates a specific anatomical criteria. Less and less nowadays, we're trying to get by using fenestrations and other tricks to lessen this burden. Compared to the open surgery, of course, the open surgery is more invasive. It usually comes with longer hospital stays, more morbidity. It usually is, though, more durable, and it can be used to treat infections in certain conditions, and it's way better in most of them. And it's more applicable to variable anatomy because as surgeons, we can build many things on the open side. The indications are going to be highly dependent on the anatomy and the localization of the lesions. There's no guideline, of course, that's going to replace clinical judgment. It's really important in these cases to discuss with colleagues and to make sure that we have a clear idea of what we can and cannot do. Size is going to be the key component, and we're speaking in diameters usually, but also volume in some case for the indications to treat patients. The growth is another consideration that has to be taken that has to be in your mind when you think about following these patients, and other specific considerations regarding collagen disease and others have to be taken into consideration too. As years have passed, the endo first approach has gained more and more ground. And what I mean by that is we used to only think endo could be for specific cases that were not candidate to open, and more endo seems to be applicable to different anatomical areas. So on the ascending, of course, open surgery remains almost exclusive for this segment, but now there's the first endo case reports, as I said, for the endobentos and all these new technologies that are going to come in the next few years. In the arch, the open is still way more used than endo, but it's gaining ground there too. Descending thoracic aorta for simple TVARs, now it's very much endo first for most of the cases, besides maybe the collagen diseases and the infections. For the thoracoabdominal aorta, there's also more endo than open now, but there's still a good place for open in this segment. And for the abdominal and post-dissection aneurysms, there endo is gaining also a bit more ground, but open surgery still has a good place and a good role to play in these segments. Sometimes I just wanted to make sure that this was understood. Sometimes we endosurgeons we try and we tend to go too far. Sometimes open can be the good solution. So we really have to make sure that we look at each patient and that we choose something that makes sense for them and not just for us. So first, for the indications, we'll speak about the aneurysms of the arch, and then we'll go through the thoracic segment, the thoracoabdominal segment, and the abdominal segment, and then we'll have a small discussion about special consideration about this dissection, since it's a bit of my specialty. I like to speak a bit about that, but I'm gonna try not to bore you too much with it. So brace yourself. This is going to be the part of the presentation that I think may be the most boring for you, but also it's very important to understand the criteria of size and others to make sure that in the future you can make adequate decisions on different segments of the aorta. For the arch specifically, the CCS had a recommendation in 2014 that recommended basically to start thinking about the treatment of the arch at 6 centimeters. This was lowered to 55 millimeters by the ESC and the CCHA in 2022. So on the cardiology, cardiac surgery side, that's mostly what I've found and also what I've been discussing with my colleagues in cardiac surgery. For the vascular surgery guidelines for the arch in 2019, the ESC and the EACTS and the ESVS spoke about a cut at 55 millimeters. The SVS has no specific guidelines for the arch, but has many on other segments that we're going to discuss a bit further down. And the CSVS, the only recommendation that has been found is in 2014 with the arch at 6 centimeters. So we can see 55, 60 millimeters. It's a bit everywhere around these areas in all guidelines. There's also a growth threshold, so it's a consider. It's not necessarily a you should treat necessarily. It's a consider that a growth of zero point 0.5 to 0.55 centimeters every 6 months or zero point 0.3 centimeters every year for 2 years in a row would be a criteria to consider surgery or endovascular treatment. For Marfan and Ehlers-Danlos, the cutoff is at 5 centimeters instead of 5.5, or even 4.5 centimeters if there's a history in the family of rupture or other complications due to the aortic disease. For Lois Dietz, and this is more of a thoracoabdominal recommendation in the cardiology guidelines mostly, they tell us to consider a treatment even lower at 4.2 centimeters and up. So if we want to recap and make a bit of sense of these guidelines, size in terms of absolute size is between 5.5 and 6 centimeters for the arch. And it's, in my opinion, highly dependent on the anatomy of the lesion. Look at your patient, look at their frailty index, look at the renal, the pulmonary, the cardiac functions. Not all patients look the same. Not all old patient looks the same. So you really have to make sure that you select your patients correctly when you do arch treatment, because this is usually very risky procedures, either if you do it open or endo. So it's very important to select your patients correctly. Many, if not most of the patients that we see may benefit more from for a treatment at 6 centimeters and up because they are sicker, they are older than the usual patient population that we have, even in vascular surgery, and cardiac surgery patients tend to be younger too. A growth of more than 0.5 centimeters a year or 0.3 centimeters for 2 years in a row could also be considered, but it's a consider for me. It's not necessarily a we have to treat. So this is to take into consideration. For patients undergoing ascending repair, this is something specific to the cardiac surgery guidelines. You should consider to treat the arch too. If the arch is at 4.5 to 5 centimeters when you're treating the ascending, I think it makes a lot of sense because treating the arch first before having to do a redo surgery makes a big difference for you guys, but also for us in vascular surgery when we want to do the rest of the aorta. For collagen diseases, please try to avoid endovascular grafts for now if you're not lending in some Dacron or other synthetic structure. For Marfan's or Ehlers-Danlos, 4.5 to 5 centimeters. For Lois Dietz, 4.2 centimeters. For the descending thoracic aorta, the CCS recommended in 2014 a big diameter for the cutoff of treatment at 6.5 centimeters. I believe they were mostly referring to thoracoabdominal aorta, but it was very much written as descending. So it's something that changed over the years in the ESC and the ACC/AHA guidelines. Now they also say to consider treatment at 5.5 centimeters. It's pretty much the same thing that we say in vascular surgery. The ESVS and the SVS recommend considering treatment at 5.5, but only in favorable anatomy and patients that are low risk. When you're high risk or you have a non-favorable anatomy, then they say consider treating at higher levels, and the ESVS even says at 60 centimeters. And I think it's a good recommendation for most of the cases. CSVS also went with the CCS's recommendation with 6.5 centimeters in the descending aorta, but that's an old recommendation from 2014. So the recap for the thoracic descending thoracic aorta is to start considering treatment at 5.5 centimeters and up to 6.5 centimeters, depending on the patient anatomy, but also the frailty of the patient. So again, please look at your patient, make sure that you select them correctly, and you can wait until 6 and 6.5 centimeters without a problem if these patients have a lot of comorbidities. The more complex the repair, the higher the threshold should be. And this is true for, I'm fairly certain it's true for open cardiac surgery too. For example, if you have this kind of aneurysm in the descending thoracic with a lot of place for the landing zone in proximal and distal aorta without having to covering any axial artery, maybe you could consider treating it at 5.5 centimeters. But if you have something like this with no landing zone in zone 3 and you have to go higher in zone 2 and even maybe zone 1, then you should most probably consider treatment only at 6, even 6.5 centimeters. The overall guidelines for the thoracoabdominal aorta follow the same kind of trend. The only difference is that almost nobody now wants to necessarily treat patients with a thoracoabdominal aorta that's 5.5 centimeters. We went up to 6.0 centimeters, even 6.5 centimeters if the patients are highly comorbid or anatomically complex. The exception is rapidly enlarging aneurysms. So same thing as the thoracic segment, zero point 0.5 centimeters, but over a year this time, or zero point 0.3 centimeters over 2 years in a row. So 1 year, 0.3, 1 year, zero point 0.3. This is a conflicted part of the literature. I would say if I have a patient that grows zero point 0.3 1 year, zero point 0.3 the other year, and gets to 4.6 centimeters, I'm not even going to consider operating on them. So it really depends on the patient and the absolute size. For Marfan's and Ehlers loss, they recommend operating them at 5.5 centimeters and to avoid, of course, endografts if we're not landing in Dacron, particularly for the proximal part. And Lois Dietz also, this is the main recommendation, and this is where it comes from, the 4.2 centimeters cutoff. It's a soft indication. It's, of course, case by case, and that's what we use in practice to in our team at Montreal Heart and Sacré-Cœur Hospital. The overall guideline summary for the abdominal, I'm not going to pass too long for that because I know it's a bit far from you guys, but it's important to know because if you follow patients in the aorta clinics, you're going to have abdominal aortic aneurysm too. The recommendation for treatment is 5.5 centimeters for men and 5.0 centimeters for women. There's also a criteria for rapid progression, but it's 0.5 centimeters for 6 months or more than a centimeter per year. So a bit more progression needed before we start thinking about an indication for the abdominal segment. This excludes staphylococcus aneurysms, collagen diseases. We have lower thresholds for that, but it's not clear what the thresholds are for that. The thresholds are for that. First, specifically for aortic dissections, for type A aortic dissections, of course, as you know, surgical repair is still very much indicated. There's been a lot of studies and a lot of guidelines built on aortic dissection in the past 10 to 15 years. It's a big subject, very talked about in different meetings. And this is absolutely not to scare anyone, but the ESVS started the vascular surgery European guidelines and statements arrived in 2025, and they basically state also that we could try to think about treatments of the ascending aorta if there's specific disease like focal rupture and other diseases that have a landing zone in proximal and distal aorta, which almost never happens, but this is something to take into consideration if you have patients that are more sick. And also, there's the first case reports of the endobental techniques that are being published right now. So it's coming to for the ascending aorta. For type B and residual type E dissections, the indications to treat are a bit more complex and they're changing rapidly. Of course, one mainstay that's been there for decades is the initial medical management. Still the most important thing to do, inotropic DP and DT control, the systolic blood pressure less than 120 and even 100 if you can, mean blood pressure of 60 to 70 millimeters of mercury, and try to use a beta blocker to get the heart rate lower than 60 to 80 if possible. First line of treatment is IV beta blockers, and then you could use basically anything you want as a second line. Endovascular treatment depends on two specific things. First, the easiest is complicated versus uncomplicated dissections. but also on high risk features. And this is the biggest point of debate right now, and it's being studied as of now, so we'll know more in the future. If we go a bit in this specific subject before we go to another segment, before 2010 was pretty easy. Complicated dissections, so ruptures and malperfusions, you go straight to treatment either by TEVAR or open surgery if it's not a candidate for endovascular intervention. If there's no malperfusion or no rupture, then it's called an uncomplicated dissection, and then we would just treat medically. Then registries and other reports came out, and the recommendations changed a bit, but not too much. They just added a high clinical risk where you could find the uncontrollable hypertension of more than 12 hours of duration or intractable pain that were added to criteria that could make you consider treat with surgically instead of just medication. This was published around 2010, 2013. After that, there were different reports in observational studies for medical treatment in 2015, in prospective trials in 2013, and in the different registries and meta-analysis a bit later in time. What we understood about what seemed to be uncomplicated type B dissections was not that benign after all. So the overall mortality at 5 years was systematically in between 19 and 42%, with more than 20% risk of reinterventions over 3 to 5 years. For the majority of them were for aneurysmal degeneration. So it's not that benign as a pathology, even if it looked like it before. The most talkative survival curves are from instead XL, a prospective trial, and the IRAD registry, where you can see that there seems to be a benefit of TVAR in uncomplicated type B dissection compared to medical treatment. And this survival benefit seems to be more apparent after 1 to 3 years of follow-up. The aorta-related survival, specifically of all uncomplicated TBAD treated with TVAR versus just medical therapy, was also apparent and significant at 3 to 5 years of follow-up. So it's not necessarily as benign as we think. But should we treat all the uncomplicated type B dissections with TVAR? Certainly not. And this is where we have a big debate right now. What we know from the guidelines is from these studies that were published, the ECS, the ESVS, and the ESSAIHA and the SVS, the STS2 started publishing guidelines with different criteria that could be a gray zone for the analysis if you should treat with TVAR or continue with medical therapy. And they would advise at that point to think about treatment in young patients, in patients with high radiological risk, like a diameter of more than 40 millimeters, a false lumen of more than 22 millimeters, a primary entry tear of more than 10 millimeters. And these were all found, as we would see in different kind of studies. But the treatment with TVAR or surgical treatment of the type B dissection came more about the high risk versus low risk of complications, mortality, and degenerescence over time at that point in time. So what happened with the high risk criteria, where they came from? They came from different reviews of literature and meta-analysis. Unfortunately, the evidence in these meta-analysis is mostly retrospective. Not all of these studies were of high quality, and the criteria that were found in these studies were sometimes only based on a few patients that had a complication with, for example, the entry tear of more than 10 millimeters. But then these criteria got shoved on guidelines and guidelines after guidelines without really much looking into it. And then a few years ago, started coming all these different experts saying, okay, we should analyze this before we treat everyone. So now we have three prospective trials enrolling as of now. We have the Improve AD trial in North America, the Sunday trial in Scandinavia, and the Earnest trial in the UK. We're trying to sort out which criteria should really be a consideration for treatment with TVAR specifically compared to medical therapy alone in this specific population. So for now, the treatment for type B and residual type A dissections, when they're complicated, that's for sure. We should treat them with TVAR or other means if we have problems with simple TVAR, of course. And we're speaking about malperfusion and rupture, but also uncontrollable hypertension and intractable pain. But we may consider treatment with TVAR2 if the patient is young with aneurysmal aorta, and we're speaking about an aorta of more than 40 millimeters. That's the criteria that was mostly found in a lot of these studies. So this is one of the areas where we could think about it. But some experts even say this is a treatment that should be reserved in research protocols. But we'll know more in the next few years. So let's try to keep updated on that. This is going to be fun to see. So for the endovascular aortic repair, case preparation is probably the most crucial part of this presentation. So I'm trying to get out all of what we need to know, but of course, this is a subspecialty that needs a lot of training. So don't hesitate if you have questions, but also to train yourself if you want to be in a group treating aortas to make sure that you have all the expertise that you need. The treatment of the aorta, specifically all the segment in the arch and the thoracic and thoracoabdominal segments, is multidisciplinary by definition. So you gotta have friends. You gotta have all this team that is around you. For us, we built a team with cardiac vascular surgery, angioradiology, cardiology, and other specialists in the medical field that are interested in the domain. And we created these clinics based on all the expertise of everyone. And as I can say myself, the more you are, the better for the decision making and for making sure that every patient has an adequate treatment and mostly the optimal treatment for them. The Arctic team should be able to propose open, hybrid, and endovascular treatments to every patient and to make sure to balance the pros and cons of each solution, that's for sure. And for that, you need expertises in different fields. Think about the future of every patient's pathology. And what I mean by that, and it's probably a vascular surgery deformation, I mean, please, if possible, build longer hemiarches, longer ascending repair. We love these to land if we need our grafts. Please do consider frozen elephant trunk. It's an amazing technology that we love in vascular surgery because it creates a landing zone that's perfect for the distal treatment. We can debranch it for you if you want and make sure that the subclavian doesn't have to be sewn if it's too far. No problem. Every surgeon, if vascular surgeon is gonna be happy to do it if ever. Um, I wanted to make sure to readdress the fact that every patient has a different comorbidity and anatomic profile that will modify the way that you approach their treatment. And there's no one treatment fits all. So you really have to think longly and discuss longly about all the options that are available to you before taking a decision and offering it to the patient. If you want to prepare for an aortic case, you got to know your aortic zones. I assume most of you know them. I just wanted to put them back here. A tip for the arch, I start with zone 3. Zone 3 is just after the subclavian. It's the first 2 centimeters after the left subclavian, and then you go up. So every artery has a zone. So zone 2 is for the subclavian, zone 1 is for the common carotid on the left, and zone 0 is the brachiocephalic and the ascending aorta. For the descending aorta, start with zone 3 again, and then you have two distal thoracic zones split in the middle at T6. So 4 is before, 5 is after, and then you have each artery that has their own zone. So celiac is 6, mesenteric is 7, renals are 8, and then you have the inferior mesenteric and the infrarenal aorta, that's 9, and then you go down by 10. At every bifurcation, you have another zone with 10, 11, and some even describe the femorals as the zone 12. Know your options. So what you have as options is getting bigger and bigger in terms or wider and wider in terms of options at every passing year. So right now I tried to put everything that we have out there so you have a bit of an overview. Of course, you have all the open options for the ascending, the arch, and the hybrid options with frozen elephant trunks, with other grafts that you can put in place, or even elephant trunks that are still used as of today. These are the most durable options that you could think of, that's for sure, for the arch and for the ascending aorta. They, of course, propose a significant procedural risk. So they require fitter patients. They require usually extracorporeal circulation or rest and hypothermia. So these procedures are technically complex and they come with their own risks that we're gonna a bit see later. And I'm pretty sure Dr. Moon is gonna be way more apt to discuss the risks with you. If you want to go in the total endovascular options, then you can build or have built a custom-made endograft. We call them CMDs, so custom-made devices. We have them in the arch, we have them in the thoracoabdominal segment, and we're going to speak about that a bit later. You have the Cook-Zenith arch, the Terumo-Bolton graft, and other grafts that are being put on the market right now. They're excellent option in specific scenarios. I think they perform the best compared to other options, in particular in arch aneurysms, because the distance in between the walls of the aorta and the axial arteries, meaning the brachiocephalic trunks, is usually bigger. So some of the options being fenestrated grafts can't be used in this specific scenario because they're not going to seal well. They're typically not off the shelf though, so you need to wait 4 to 8 weeks in between the moment you order them and the moment you get them delivered. So they're not adequate in emergencies. They're also technically very complex procedure and they're expensive. So that's taken into consideration. You could also use parallel stenting. I would advise, and this is a personal opinion, but also from the literature, against using them unless you are in emergency and you have nothing else to do, because these technologies have been replaced by some other things that we can do, and the parallel stent grafts are vulnerable to thrombosis and periprothetic leak. So it means that you could have endo leaks that basically make your treatment not functional for what you want to do, which is usually isolating some kind of pathology as an emergency. And the leaks, the gutters that they create, may be very hard to treat after that. You could also use single branch devices. We used to have the Mona LSA Medtronic grafts, but it was recalled because of some stents proving some cases of rupture basically in the fabric. Now we have the Nexus graft for zone zero landing, but we mostly right now we have the TBE graft. It's a unibranch graft by Gore that is now available in Canada and that we can use as of this year. We can also use PMEG grafts, and by PMEG, the main difference between PMEGs and what we can do with single branch devices is that we don't need the debranching, and the grafts are also way cheaper because you can use any thoracic graft that you have on your shelf besides maybe PTFE for the lasers. So laser fenestrations is something that you can do in the arch too. Um, it's a great option to have a laser in the place for different holes that you want to puncture anywhere in the in either in the grafts or in the native aorta. It could be very life-saving in some cases. But for the arch specifically, it necessitates temporary cerebral malperfusion while you're deploying your graft and just before you poke the hole. So that's to be taken into consideration. You can't build windows for now or fenestrations that are more than 8 millimeters of diameter because there's been in vitro studies that prove that there could be some tears in the fabric if you do that. It's also possible that in the future we could have some tears or leaks in the grafts because of the inability to reinforce these fenestrations. It's not a good thing to do it on PTFE grafts like the core grafts because sometimes the hole just doesn't poke. The laser doesn't poke a real hole in the graft. So it's to think about too if you have gore grafts on your shelf. Back table modification is another PMEG that could be used. You can reinforce the fenestrations that you do. There's different techniques that you can use, and you can use a through and through wire, which could be life-saving for the positioning on the graft in the arch since it kind of does it by itself by the through and through wire. The options for the descending thoracic aorta are multiple, so this is just an overview. Of course, the Cook Zenith Alpha is an excellent graft for the day-to-day basis when you want to do TVAR. It comes in its own sheath, so this is handy for that. Beware of the Cook sheaths though, they're the only ones that are calculated with the inner diameter. So if they tell you that it's a 20 French, it's actually an inner diameter of 20 French, so it's mostly a 21.5, 22 French of diameter. So it's very important to take into consideration because the other graphs usually speak with sheets in the outer diameter, of course. There's also very long shafts for these prostheses, so it means that you're going to need very long wires to go with that. The Medtronic Valiant Captivia is the same kind of workhorse craft. It's very good. It's pretty much the same, in my opinion, than the Cook craft. Easiest deployment by far. It's just a handle that you can unscrew, and then there's a little button for the top cap, and Doesn't necessarily need a sheath by itself because you could put it bareback, but most of the time I prefer having a sheath for stability and comfort. It also gets your access to be bigger, but if you can afford it access-wise, then I think it's better to put a sheath on. The shafts are shorter than Cook, though, so that's a good point. We also have the Terimo Bolton Relay Plus, which is a bit of a new graft in Canada. It's been used for a couple of years in Europe. I'm less familiar with it. I used it a few times in my fellowship. I didn't use it here specifically, so it's been years and years since I used this graft lastly. But the thing that I can say about it is that there's some kind of a telescopic deployment. So the graft deploys in two different parts, and this part is something that we may be more uneasy with in the usual case, but it could be good for tortuosity in the arch, which happens a lot of the time. Another graph is a Gorsi tag. The difference with this one is that you have active control, so you can actively bend the proximal part and angulate it to accommodate angulated arches. So that theoretically and practically leads to less beaking and angulated landings. It's also a two-stage deployment, so you have a 50% deployment and then a 100% deployment. So there's less flow pushback when you're doing the deployment than the other graphs that occlude basically all the aortic flow at the same time. So you can have some type of pushback that's more significant in other graphs than this one. And there's the option to move the graft also at 50%, a bit back more than pushing it up. This is always the case. Pushing a graft up is always more difficult than pulling it back. So it's better to try to deploy the 50% a bit higher and then to deploy the 100% at the place that you want. So it's a good graft also for teaching hospitals because this way you can correct some of the initial mistakes that we can do in the deployment. It's two times more expensive than the other grafts, so this is something to take in great consideration in Canada. It's a great topic right now. The price of these grafts is extremely significant. So I don't advise to use this graft in any scenario, mostly in specific scenarios with angulated arches or in teaching hospitals. It also needs a sheath, so it increases the profile of the whole delivery mechanism. Here are the little IFUs of these grafts, just so you know. You can treat aortic aneurysms if you have a landing zone that's up to 42 millimeters with these grafts. I would advise against going higher than 40, 41, but you could go up to 42 usually because the grafts are available in sizes up to 45. The proximal landing zones is always around 20, and the distal landing zone too, besides unless you're using Bolton, where there's a bit of a variability there. For the thoracoabdominal aorta, we'll speak first for the elective CMDs. It's a bit the same thing as for the arch, but it takes up to 6 to 8 weeks to deliver them. The Cook one is called the Cook ZFen, or all of these Cook ZFen delineation is by far the most used in Canada and the US. The reps can help you with the measurement. So you basically send the images to the rep and you discuss with them to get the best plan for each patient. There's the most data out there about this graft compared to the other ones. The profile is also pretty good. It's up to 22, so 24 French because it's Cook, but it's also not catastrophic. We try in vascular surgery to cut the size of the introducers, and right now everything over 24 French is usually considered very big. So we try to avoid if possible because we have more complications in the accesses because of that. It comes as a unibody component, and then you can add on a bifurcated component that comes with it, usually in two parts or more. The Remote Trio CMD is the new kid on the block. It just came out in Canada. It's up to 5 fence that you can build, so it's a bit more restricted than what you can do with Cook, but still pretty good. The thing that's maybe the most interesting about it is the low profile. It goes maximum 19 French, so compared to 24, still a great improvement. It comes in a unibody, but also in a bifurcated body, so you could have a whole integrated graft in only one piece, and then you can put the limbs for each iliac after that. So this is something interesting. It's not something most of the surgeons in Canada are used to. This graft is maybe used a bit more in the future. Pretty sure Cook is still gonna stay the main graft though for the thoracoabdominal segment. Thermo also bought the Anaconda graft a few years ago. It used to be a bit popular in Europe, and it's losing a bit of popularity because of the leaks and durability issue. The fun part about it is that you could put the fenestrations a bit everywhere you wanted because there's no Z stent in the zone that is used for the fenestrations, which is different than the other companies. The drawback of it, of course, is that maybe there's not enough support, and that's why there's problem in the future. It's seldom used in Canada, as I know. There's also the Jotec E inside. That's another CMD that you could use, and that's there's not a lot of literature about, but it's mostly used in Europe. For the thoracoabdominal aorta, we also have emergency branch devices that can be used in different scenarios. The Cook T branch is the most well-known, the most used to. A few centers have it off the shelf. There's some in Ontario, and I believe there's some in British Columbia too, but it's an option that you need to be aware of. These are branches that are already off the shelf and that you could use in anatomically about 50-50 of the patient, 39 to 67% in the studies. But if the patients are candidates, it's a good way to bail out of a bad situation when you have a rupture and you have a patient that's really frail or has had previous surgery in the past, so has a hostile abdomen or other things like that. So it's something to think about. The Gore just got the Gore 10B approved in Canada too. It's kind of an alternative to the T branch. Thing is, the inverted branches that for the renals that are on this graft have been proven recently in a study about the first grafts implemented in the US to have more thrombosis. So there's a signal there of more thrombosis of the renal limb. So it's something to think about if you want to use this graft in the future. And the anatomical suitability is a bit lower at 23 to 44%. If you are in an emergency and you don't have access to these graphs, you can also think about PMEGs. So the first one and the most used one in the US is the chimney technique. As in the thoracic segment, the same kind of complications can arise in the abdominal segment. So you have gutters that can create around the axial stents in between the aortic stent, the wall of the aorta, and the axial stents. And these gutters can go straight into aneurysm and create a type 1A endoleak. So it's something to maybe use if you have nothing else and you need a bailout, but not necessarily on a day-to-day basis. You can also create yourself back table modifications on a graft. Usually we use thoracic grafts. We can use diameter reducing ties that we can do ourselves. I'm not going to go into great lengths today about this specific technicality because again, this would take a long time for maybe a low yield for cardiac surgeons, but it's something that can be done. We also can use the laser to fenestrate a thoracic graft again, and then puncture holes for each artery, usually the four of them in the abdominal segment. For the infrarenal aorta, I'm gonna go very fast about this because it's less of a concern for you guys, but there's many grafts that you can use either in the Cook Zenus Flex. You have the Medtronic Endran 2, the Turmo Trio, and Anaconda that are used in Europe mostly. The Gore Excluder and Conformable that have different criteria that could be useful in certain specific scenarios, and the Endologic Alto that's specific that's a particular graft with polymer inside for angulated and conical necks. There's of course other grafts, but it's just infinite at this point. There's also iliac branches that we have right now for the iliac aneurysms, or when you cannot lead where you cannot land in the distal common iliacs, either from the Cook or the Gore armamentarium. So you have the IBE and the IBG, as we call them. The technicality about using them is it's pretty simple. Basically, you deploy them in body and then you go contralateral and you cannulate the contra limb for the internal iliac. This way, you can stent both the internal and the external as a secondary step. For the dissection, you have different options. You have the Cook TX2 and bare distal dissection stents that can be used. The dissection stent is particularly interesting to me, in my opinion, because you could use it to relaminate the whole thoracoabdominal segment, so infradiaphragmatic, and create a new aorta, even if there was dissection before, to get rid of the whole process in the future. I think Dr. Moon is going to speak to you a bit about the EMD stents, an extremely interesting technology, and I think he is an expert in the domain. So I just wanted to put it there so we have a bit more of an overview. You also can do laser fenestration on the native aorta or in the grafts if you need for dissections, and you can use candy plugs. So candy plugs is a specific thing that we use in the false lumen to occlude it. So what we do is we extend the TVAR up to usually the celiac, and then we can put the candy plug in the paradiaphragmatic false lumen aorta. This way, by installing this plug and by dilating the TVAR, we can crush it and create an occlusion, or at least a good partial occlusion of the false lumen. For case prep, now that we have the material done, that we know what kind of team we have, all patients should have a CTA and measurements should be done at least by multiplanar reconstructions for TVARs and centerline reconstructions for complex repairs. So what I mean by that is that you have to have some kind of software, either Terra Recon, 3Mensio, or Single Via, or all these softwares that help you reconstruct the aorta and make a better idea of what's going to happen when you get the graft up there. But also the center line that you can do with these softwares helps you build the graft itself. So you can't build a fenestrated graft without it, even if it's either if it's a PMEG or a CMD, so something that you order by the company. That's what Cook or other companies are going to do when you give them the images. They're going to center line them and use it to measure the diameters of the aorta and every axial artery. The size of the aorta is measured usually outer to outer. So what I mean by that is that you have to go a bit further into the wall of the aorta to measure the complete diameter. That's how we do it for the rest of the aorta. I know that there's some different criteria maybe for the aortic root, so I just wanted to specify for the rest of the distal aorta. That's how we measure it. Of course, if you have a chronic type B or residual type A dissection, then measuring the inside of the true lumen can be very handy for different kind of landings if you want to build some grafts, but most of the time it's outer to outer that we measure. When you prepare for a case, take your time. It's going to take time. It's going to take hours to prepare cases, and that's normal. Measure the aortic wall and all the axial arteries diameters on at least the 20 millimeters of seal that you need. And this means that for each artery, you're going to complexify a bit your treatment. So build yourself some documents that you can print for the procedure. When you arrive, you can print them, put them on the acrylic shield, discuss with other people that are going to be intervening in the case. Usually the case prep for me takes about 3 pages. The first page is the case, the consideration for the specific patient and comorbidities and other things like that, or specific things that we need to watch. Second part is most about the angles, the stents that we're going to use for the axial artery and the main stent, and other tips and tricks about some different things that can happen. And the last one could be about the material specifically, other than the stents in most cases. So that's the kind of preparation that you got to do if you want to make sure that you have a successful day when you get to the surgery, or that you have as successful as it can be. Because sometimes you can't control everything, and it can be perfect at first. So I just want you to know when you get to do these kind of procedures, there's gonna be some things that don't happen as you expect. So try to expect the unexpected as much as you can. Also, for basic consideration for case prep, you should have 2 centimeters of seal proximal and distal to the pathology, so it's easy for a TVAR to explain. So you have to make sure that circumferentially you have a stable diameter of the aorta for 20 millimeters. That helps you have a Z-stent that's going to completely cover and seal the aorta and get the flow to go only inside the stent graft and not around it in the pathology that you're trying to treat. It's very true for aneurysms, but also in some cases of dissection. But it has also to be adapted to the clinical scenarios that we have in the real world. So what I mean by that is sometimes it happens to us still to say, okay, there's 15 millimeters of coverage there, but I don't need to cover this crucial artery or do a fenestrated graft that could be very much riskier. So let's try to do this, and maybe in a second time we can do something further up if it doesn't work, compared to landing landing in a zone that would give us 20 millimeters of seal, but then having to do something very more complex, like a zone 0 landing, for example. Think about your accesses. Define what you need before the case happens. Do you need a brachial access? Do you need an axillary access? Do you need a radial access? Do you need one or two femoral accesses for your case? Think about the tortuosities of these accesses. Are you planning to have any difficulties getting up? And this is also true for the aorta. Usually, when you have an aneurysm, it can displace the whole aorta and create many angulations that can be hard to get through. So think about it because there's some stuff that you can do, like having longer sheaths that could help you have less difficulties getting up when you have more tortuosities. Think about the size of your sheath versus the artery. And what I mean by that, I put on the top right of this screen a little chart about the usual French to millimeter conversions that we need for a bigger sheath. So 16 French is around 5.3 millimeters, and when you get to 24 French, you get to 8 millimeters of diameter. So you need good accesses, or at least you need to be aware of what you're going to put inside maybe suboptimal accesses. What I mean by suboptimal accesses is accesses usually that have calcification or stenosis. The example that I like to give is if you have a 6 millimeter artery, but there's no calcification around it. I'm not really shy about using a 20 French sheath, even if you look up there, 20 French means 6.7 millimeter of diameter, but I'm fairly certain it's going to pass without much problem. But if half of the artery is calcified and I'm trying to use a 20 French sheath, then I'm going to be aware that I may have a big problem at the end of the case or in the case. So maybe I'm going to try to use something else or think about an alternative or pave and crack or do something to get this access to be of better quality. Or I'm going to be aware that I may end up with something that I don't like at the end of the case. If the artery is circumferentially calcified, then I would advise against using anything in French size that is bigger than the artery, and that just makes sense because you may rupture the artery at that point. For dissection, specifically for the case prep, the main goal usually is the entry tear coverage, and usually it's the primary entry tear that's the most important to cover compared to the secondary entry tear. It's specifically true if you're trying to treat distal malperfusion. So it's very important to examine your patient correctly when you have a patient that has a dissection. See this patient, make sure that you have a brachial, radial, femoral, and distal pulse idea. So before surgery, you can know what to expect after. So if before you don't have pulses in the legs and you're doing a proximal repair, and then you don't have pulses at the end of this, then you should either do another scan, do another exam, or maybe try to cannulate to try to fix this probable malperfusion straight after the case, because the more ischemia you have, the more death you have to in these specific cases. Also look for mottled extremities before starting. It's a very bad sign. The patients that we have with, I would say, half of the body being mottled, usually they don't fare well. Be also aware of a smaller arch versus greater arch coverage for the specific needs of every patient. What I mean by that is that when you get into the arch, because usually when you have to cover an entry tear, it's in these zones between zone 3 and zone 2 and zone 1. In these cases, sometimes the arch is very angulated and sometimes the smaller arch, so the portion that's just at the lower portion of the arch is not does not offer the same seal as the greater arch for every pathology. So as you can see in this image, for example, the greater arch is the one that I need to take care about. I needed to take care about in this case. So I needed 20 millimeters of coverage in front of this huge entry tear at the origin of the subclavian artery. Whether I have a long coverage in the smaller arch is not really useful here. I really need to focus on what the problem is and where it is compared to the greater or inner arch. Know also what you are treating. If you're treating malperfusion in a dissection case, then you have to know what kind of malperfusion you can have. So there's two basic types. You have static that you can see on the left. So it's basically when the dissection goes in the artery and creates a stenosis that's always there with the cardiac cycle. Or you can have a dynamic obstruction that you could see on the right with the SMA being partially occluded with the beatings of the heart at every beating of the heart, and this could cause ischemia too, but this is most solvable by a proximal stent graft, and to the left, even if you put a TVAR, you may not have a different kind of outcome because basically the pathology is directly in the SMA at that point. If you're treating rupture specifically, then you may want to look at your paradiaphragmatic aorta in dissection cases because this is where you could most of the time obtain a seal. And the seal is important in the distal part of the aorta when you're treating a rupture. For zone 5, so this zone in the paradiaphragmatic aorta, you have different options that you could use to seal in an emergency, either by Knickerbocker technique, which is using a stent graft that's a bit oversized in the thoracic, distal thoracic, or you can have it built, but if it's a rupture, you don't have it on the shelf. So you can use a TVAR that's sized to the adventitia on both the extremities of the aorta, and then you post-dilate it in the paradiaphragmatic segment to obtain a circumferential seal in the thoracic segment, precluding the blood from going up there because the rupture 90 plus percent of the time is going to be in the thoracic aorta if it's an acute pathology. You can also use the stabilized technique, which is basically the same kind of calculation, but instead of using a covered stent directly up to the celiac, you can use a stent that's going to do the circumferential uh, isolation, but then you use a distal bare metal stent that's going to be able to relaminate the whole distal aorta and get rid of the pathology overall. You can also use a candy plug if you have some on the shelf. It's pretty hard to have these on off the shelf, but usually we have one unused on the for us in Montreal. It's on the island, so we can ask the rep, and sometimes they have something that we can use, and it can come handy in a rupture case. Be also aware of the origin of the true and the false lumen for each axial artery. So, for example, here you have a right renal coming from the false lumen. You got to know this before you go into a case because after you start favoring usually the true lumen, these kind of things can become a bit tricky. So you have to recheck your arteries after the case to make sure that the perfusion is good in all four arteries in the belly usually, but also it can happen in the arch. Take special care about the accesses in dissections because there can be many things in dissections that go wrong and some things you can plan. Are your femorals high in terms of bifurcation or are they at the adequate level on the head of the femur? Is it easy or a complex entrance that you're gonna have when you get inside the arteries? And what I mean by that is that you have to reconstruct the arteries for dissections to see if the true lumen is in line with the aorta, in the overall axis of the aorta from the groin to the thoracic aorta if you need to treat there. So I have to identify the true and the false lumen everywhere and make sure that you understand where your guide wire is gonna end up. You can also use IVUS if you want to help yourself in the case, but it's not necessary, in my opinion, even if the guidelines say it is. You can manage without if you understand what you're doing. Easy accesses can look like this to the left. So you have a true lumen that's directly in line with the external iliac and the femoral artery. So this way you know you may go through or you just have to aim up when you get to the iliac bifurcation. And to the right, you can see a very disgusting case that we had a few years ago where the accesses are pretty much invisible. You only see the common femorals that are in the true lumen apparently, and then we have to figure out what we're going to do with this axis. And we know already that the case is going to be rough from the start. So knowing it makes it a bit less difficult when you get inside the case. Now, for perioperative consideration, one thing that's very clear, there has to be one captain on the ship for every case. So that means that even if you have a multidisciplinary team, you gotta target someone that's gonna have that's gonna be the main captain of each case. Each specialist has, of course, their own set of skills. So I advise use them as much as you can. When it's the specialty of someone, use it. So this way the case goes a bit more straightforwardly, but also identify the leads of the case that will be lead of the case that will be responsible for following the steps for the fluidity of the operation and for the division of the tasks before the case happens. Also, when you look at your accesses, you have to take care about are you going to do a pre-closing or are you going to do a cut down for the arteries that you want to access? The pre-closing is using usually a ProGlide, but it could also be a Manta or other devices that you could use for closing the artery after. The Manta is used after the whole case. The ProGlides are using before, so it's mostly about this specific device. It's good to put two when you have accesses more than 8 French, and it's good if the sheaths are bigger than the artery that you're trying to access. So this way, you know the little stitches that you're putting in from the ProGlide are gonna anchor into the wall, and they're not gonna create a stenosis when you close them. If the hole is too big for the artery, then this is not a good device for you. The iliacs have to be not too torturous if you want to use it and make sure it's functional, but still you can, there's many cases where we thought, oh, it's probably not going to work and it ended up working. What I advise against is if you really doubt that it's going to go through, specifically go through, I mean, the sheaths are too big for the arteries or the tortuosity are extreme, and you think, oh, my gut feeling says I should maybe not do that, then cut down. Or be prepared to do the humbling 8 p.m. or 2 a.m. embolectomy that's going to ensue if you don't listen to yourself. And this is going to happen if you do endosurgery, of course. For neuroprotective maneuvers, the first thing that we have to respect once we start covering is a map higher than 80 to 100 millimeters of mercury as soon as coverage starts. It's true also for dissections, but I modulate it for on a case-by-case basis because, of course, sometimes the dissections are acute and there's complications, and we don't want to have a too high of a pressure. So it's something to take into consideration when you're doing these cases. Think about staging the case too. Staging means doing a first TVAR, and if you're doing a type 2 repair, so the whole thoracoabdominal aorta, then waiting a few weeks and then doing the rest of the coverage. This way, you have less chances of ending up with a paraplegia. So it's been more used in the past decade, and most people right now are using this strategy with the first TVAR and then the extension TVAR or FIVAR that we need to do after that if needed a few weeks later. As a neuroprotective maneuver, what we use in our team too is the Misace protocol. So we have the enteroradiologist embolize about half of the intercostals before the second part of an endo procedure when it's a type 2 repair. So this means we do the TVAR, we wait the 2, 3 weeks, and then we do the Misace protocol, and then we do the FIVAR a few weeks after. So in the meantime, the FIVAR has the time to be ordered, to be screened, and to be sent to us. This is being studied right now by the Papartis registry. It's going to come up in the next few years, but the preliminary results are really good. It tends to divide by two the risk of paraplegia for patients. So I think it's something that's promising for neuroprotective maneuvers. And please don't park your 20 French sheath in the iliac if not necessary. If you are done with the main graft and you don't need this 20 French sheath anymore, you can taper down by putting a smaller intro and tightening your pro glides. And the more you do it, the less chances you have to have an ischemia of the leg or paraplegia because of less blood flow through the internal iliacs. Some people also use the motor evoked potentials. I think Dr. Moon may talk a bit more about this. I don't use it. I know some groups use it in endosurgery too, but it's something interesting to see if there's some hypoperfusion of the medulla while you're doing the case. So the lumbar drain, the last thing I'm going to talk about in this segment, historically it's been strongly suggested as a prophylactic measure if you had some criteria of high risk, like coverage more than 200 millimeters, coverage of the subclavian or hypogastric arteries or previous aortic surgeries, things like that. We cover less and less axial arteries right now as we go on and do these fenestrated grafts. So we don't have as much of these kind of risks anymore. The drains also come with complications like epidural hematoma and abscesses that can complicate the whole thing. And usage of the lumbar drain right now is more of a case by case basis. So that means that when you have a type 2 repair, of course, you can consider it. And I think it's advisable to think about it as a prophylaxis. But it's not the same thing as covering with a TVAR of 230 centimeters. That would be a criteria usually. But if your subclavian is vascularized and you don't have any other previous aortic surgery, I personally don't use a lumbar drain for these kind of cases. I use it reactively. And I'm going to talk to you about what it means in a few seconds. With the staging, what we know is that we divided the risk of paraplegia for endosurgery. So the risk of putting a lumbar drain sometimes outcasts the risk of the benefits, the potential benefits of it. So there's more and more literature right now about post-op drains. And what we mean by that is that for some cases, okay, we can use prophylactically, like type 2 repair, when the perceived risk is high, or previous history of post-op paraplegia, that's for sure. I'm going to use them. But when it's not these kind of cases, I usually use them reactively. So I wake the patient on the operating room, and the anesthetist is ready with a lumbar drain to put in the back of the patient if the legs don't move. And we've been lucky. It hasn't happened yet, but I'm sure it's going to happen in the future. It's part of aortic surgery. It happens to everyone. So just be aware that this is a kind of strategy that's absolutely acceptable. Regarding the outcomes of endosurgery versus open, so we're going to go a bit quicker on this. The branch CMDs of the arch, there's a meta-analysis that has been published lately on 618 patients, and this is, I would say, the top guns of these surgeries that have published this specific series in the Eastern Asia. 30 days mortality is 5.5%, 10% stroke, and 6.5 reintervention. So these are pretty significant number, but still it's not 30%, for example. And at 2 years, you have 11% aortic related mortality and 9.6% reintervention rate. When you look at backtable PMEGs, there's no meta-analysis yet. This is a pretty new technology. The original center that started doing that in south of France has more than 180 patients. And now what we know from the zone 2 landings is that it's very less risky in zone 2 than zones 1 and zone 0, of course, with 10% mortality, 3% stroke, and a 3-year follow-up with no aortic death and no reintervention. In zone 0, they have 100 patients with a 97% success rate. It's getting good. It used to be way lower, and now we're getting to rates that make a total sense with a 2% mortality, 4% stroke, and 8% reintervention. There's also a 4% rate of retrograde type A dissection. So pretty good numbers for the PMX for now. The 2 years follow-up didn't show any rupture or spinal cord ischemia. The literature about this is booming right now, so you'll see more of this in the future. Same thing with laser fan of the arch. The problem with the study about this that was published a few years ago, 247 patients, but most of them, 66% of them were in zone 2. So it's difficult to analyze the zone 0 by itself since there's very few patients. But the early mortality was good at 3.2%, the stroke rate at 4%, spinal cord ischemia at 1%, and 2 retrograde type A dissection. So good numbers for this too. And the midterm reinterventions was only at 6% at 2 years. There's also a booming literature about this, so we'll see more in the future. So I tried to compare it to what we know that would be an alternative for arch grafts. So frozen elephant trunk came to my mind. That's what we use here as an alternative in many cases. So there's this meta-analysis that came a year ago of 11,000 patients. And the total early mortality was 7%. Spinal cord ischemia was 4%, stroke rate was 8%, and acute kidney injury was 11%. At 1, 5, and 10 years, you had reinterventions from 6 to 20% or 90%, 19%, sorry. And the overall death was 14 to 32%, so significant too. When we compare ballpark, because of course it's not the same kind of patients, the same kind of surgery, but that's the kind of result that you can expect from endo arch versus frozen elephant trunk. 2 to 10% early mortality, kind of same thing for frozen elephant trunk. Early spinal cord ischemia is a bit less in the endo arch. There may be a bit more strokes, or it's in the same kind of range of 4 to 10%. The midterm mortality is pretty much similar at 1 to 2 years, 11%, 14% for frozen elephant trunk, and the midterm reinterventions is also a bit of the same, around 6 to 10% and 6 to 13% for frozen elephant trunk. So of course, this is not the same pathology necessarily, but it comes with the same kind of coverage. Endo, of course, may have some anatomically better candidates, but frozen elephant trunk may also have fitter candidates, so it's difficult to compare very accurately. But this gives you a ballpark idea of the performance of endo arch in this specific scenario. It's also retrospective data, so we don't know much, and there's the bias of the people that are publishing. There's much less data on endo arch than in frozen elephant trunk, and not all arches need frozen elephant trunk, nor they need zone 0 landing. So it really depends on the patient that you have in front of you, and every patient has to be selected accordingly. For the descending thoracic, the debate is pretty much closed. TVAR functions better than open repair with survival benefit, and evidence dates more than 10 years about this fact. For the dissections, though, we have evidence now that proved that surgical management actually fares worse than endovascular management for type B dissections and other dissections. So as of now, endo first is the mainstay for treatment in the descending thoracic aorta. For the thoracoabdominal aorta, for fenestrated and branched EVARs, we have this pretty new top surgeon analysis of the results. It's retrospective on 474 patients. Very good technical success, very low mortality, spinal cord ischemia, and acute kidney injury. And the midterm follow-up shows good results too, with mortality at 5% and reintervention rate at 16%. And we're speaking about fenestrated and branched devices after open proximal repair. So these are basically the equivalent of a type 2 repair. So just as a comparison, these are the top guns of open surgeries that publish their results on thousands of cases. And as you can see, mortality is usually around 7 to 8%, spinal cord ischemia 5 to 16%. So endo for the thoracoabdominal segments in the perioperative period of course seems to fare better, and it's not surprising because time is the is usually the enemy of endo surgery, as we will see in the infrarenal segment. But long-term follow-ups are needed to see. For now, we know that it works good in the perioperative segment, but the perioperative period? But is it going to be good on the long term? This we'll know in a few years or decades. Of course, this data is also on world experts, so it's not real world data. We'll see if the centers that fare that have less cases fare as good. For EVAR, it's the perfect example of what I was saying a bit earlier. We have four different RCTs that were built in the beginning of the 20th century, 21st century, and what they say basically is that EVAR has a mortality benefit on the short term, but this is lost over the medium to long term. At 2 to 8 years, the EVAR is equivalent to open repair in terms of mortality and aortic related mortality, and sometimes it fares even worse. So EVAR also has more in reinterventions. So endo has always had this kind of Damocles's sword on his head. It's getting better over time, less leaks and more stuff to do with it, but still, it has to be taken into consideration. And when you do an endo treatment, there has to be a follow-up for life because there can be leaks in the future. So the last segment is the follow-up. For arch graft, there's no clear recommendation, so my protocol is scan with a delayed phase at 4 to 7 days post-op, and then I do a scan at a month. And if there's a leak with no progression, I do a scan at 3 and 6 months, and then annually. If there's no leak, I do a scan annually directly. For TVARs, so for the descending thoracic aorta, I do a scan at 1 month and then a scan at 6 months. And if there's no leak, then I do annually thereafter. If TVAR is done for emergency indications, usually I do a scan when the patient is still there at 1 week to make sure that everything is sealed correctly. For aortic dissection specifically, for me, I do a scan at 3 to 7 days after the treatment if the renal function is adequate, and particularly if the dissection is complicated. And then I follow at 1, 3, and 6 months, and then annually if stable. So if you want to have an algorithm for TVAR specifically, you do a scan at 1 month. If there's a leak but it's non-surgical, you do a scan at 6 months. If there's no leak, you can do a scan at 12 months at that point. If in the leak category you have a progression of diameter, you reevaluate if you need to treat or to do a closer follow-up. If it's stable, then you can do a scan at 12 months. And then if you get to 2 years of 12-month scans being stable or remodeling, then you can think about the distancing your scans at 18 to 24 months. For thoracoabdominal FB-VARs, there's just one clear recommendation in the ESVS, but nothing that's completely widely used. You do a scan plus minus a duplex before discharge, and then at 1 month, personally, I do a scan before discharge, and then at 1 month post-op, and I didn't individualize after that, depending on what I see, because you may see some leaks and some other things in these kind of cases because there's REs coming from everywhere. So don't panic. You just have to follow them correctly, and then things should make more sense. And then you do a scan at 12 months and annually if there's nothing moving. A favorite duplex if you can at follow-up and if you have a center that has a good radiologist doing them. You have to follow these patients for life, and there's very few indications of distancing scans more than once annually because sometimes the leak can happen at 5 years out of nowhere. You have to know your specific endo leaks. I'm not going to undergo in this because this is going to be a little bit too much details, but you got to know them when you look at these scans to make sure that you understand what's happening and if you need to treat it or not. This is my algorithm for FBVARs, so scan at 3, 7 days post-op if the renal function permits it. But this is just a suggestion, of course. Then you have a scan at 1 month. If there's a leak but it's non-surgical, you do one at 3 months. If there's no leak, I do one at 6 months, so a bit closer than TVAR, for example. If you have a leak and then you have a progression of diameter, reevaluate the treatment and follow up. If it's stable, then I do a scan at 6 months if there was a leak before. And after that, if everything is stable for 6 months twice, then I do a scan every year. For EVAR, I'm going to go a bit faster. You do a scan and a duplex at 1 month. If there's no leak, you do a scan or a duplex at 1 year, and favor the duplex at follow-up if there's no leak because there's less radiation and contrast risk. You can do a scan C minus at 5 years, though, if you follow by duplex to make sure that there's no false aneurysm or progression of the disease in the proximal part that's not visible with the ultrasound. And if there's a leak without an increase in diameter, then you have to increase the frequency of the scans or duplex at 6 months for 2 years, and then annually if it's stable. You have to know your specific endo leaks for the EVAR segment too. It's the same as the TVAR. You have types 1 to 5, and it's a short read if ever you want to know a bit more about this. So the algorithm for EVAR, you do a scan or a duplex at 1 month, and then you decide if there's no if there's a leak and it's not surgical, you can do a scan at 6 months. If there's no leak, that you can do a scan at 12 months. If the leak resolves in the leak segment, then you can do a scan at 12 months and then follow thereafter. The SVS and the ESVS don't agree. The SVS says you follow every year for life, and the ESVS say then you can follow every 5 years, which is a bit extreme for us North Americans. So I would advise using the SVS guidelines and just follow them annually after that. If at the end, just kind of 6 months, you had the leak before and then it progresses, of course, you reevaluate treatment. And if the leak is stable, then you can do scans or duplex at 6 months and then annually for 2 years or for life after that. So in conclusion, I know this was a huge presentation, and I hope I didn't have you panicked. I hope this was useful. The first thing that I want to say is when you're doing endovascular thoracoabdominal treatment, you have to have a specialized team. So it means you have to have fellowships and an idea of what you're doing to make sure that everyone in the team has some kind of expertise to help further the knowledge of the whole team. You have to know your material, you have to know your options. The teamwork is the key for these kind of treatments. So make friends with us, vascular surgeons. We're very nice. I promise most of us are really nice, and we're happy to treat patients with you. It's a pleasure to know in advance also what we're going to do in the future, to have a plan longitudinally for these patients that usually are followed for life. Be friends with cardiology and interventional radiology. Sometimes they're quite helpful for the cannulation of the axial arteries or to give you a room to do these kind of cases because it's most straightforward in a hybrid room or at least an angioradiology room. And know also your medical doctors that have a passion for aorta because they can help you follow these patients correctly. The case preparation for endo-aortic cases is 90% of the case. So take your time, think and discuss about each case with your colleagues and have a plan A, but also plan B, plan C, plan D, and further down to make sure that you're ready when you're in the operation and you don't get a case where you can't do anything about a complication that's happening in the case. So you have to have a lot of material and a lot of plan Bs and Cs in your hand. Endo will never replace open surgery, that's for sure. It's just an alternative and it's an option to consider on a case by case basis. Always think what is going to happen with the rest of the aorta after what I'm doing right now. And this, I want to emphasize again on longer hemiarches. We love them in vascular surgery. Please do make longer hemiarches. And don't forget about your hybrid options, frozen elephant trunk and debranchings and AMDS, and all these things can be very much useful for the future of your patients, specifically on dissections. That pretty much wraps it up. Does anyone have a question?
So maybe what I'll do is I'll just monitor the chat for the next few minutes. If people have any questions, feel free to either pipe up or you can type in the chat and I'll read them out. If you don't have any questions, maybe I'll give you guys, let's say 5 minutes. So for EST, that'll be 3:33. And then we can come back and Dr. Moon can give his portion of the presentation. Thank you so much, Dr. Fortin. This was fantastic. I really appreciate it.
It's a pleasure. It's a pleasure. It's a big topic, of course. I wonder when I was building this, like how deep should I go? And I know there was a lot of details in there, but I wanted to make sure that you had this presentation in case you need it in the future, and you would just wanted to touch base about like what's happening right now. So this way you have the tools. But of course, I know it's a big subject, but it's also a passionating subject for me.
Absolutely. It was a very comprehensive talk. So thank you so much again.
It's a pleasure.
So I think, yeah, so I don't see any questions right now. So yeah, thanks a bunch, Dr. Fortin, and we'll give you guys a few more minutes and then we'll get started with Dr. Moon.
Okay, I'll stay for a few minutes.
Hi, Dr. Fortin. I'm Kenza Ramouni from Ottawa. Thank you so much for your lecture, and it's great to have a vascular surgeon teach us. It shows the importance of interdisciplinary team work. My question is about oversizing guidelines.
Mhm.
Can you please just give us your approach for different pathologies, acute versus chronic and so on, and maybe the segment of the aorta you're treating?
Yes. So for the aneurysms, the overall rule is 10 to 20% of oversizing. And this is pretty much for every kind of aneurysm that you're going to get. I tend to do a lesser oversizing when I treat pathologies that like when you have an infection or stuff like that, then I'm gonna go 10, 15%. I'm never gonna go higher than that because I want to make sure that these pathological walls where I'm gonna try to have a seal are not gonna have too much of a radial pressure on them that could make them dilate. For dissections, it's 5 to 10% of oversizing. That's the ballpark rule, but this is adaptable to different segments that you have to treat. So, for example, the arch, when you're doing arch grafts, usually the ascending is going to be bigger, the arch is going to be a bit smaller, and then you're going to have a bigger descending thoracic aorta. So, you gotta, at some point, you have to give in somewhere. So, you're never going to have a perfect 10 to 20% or 5 to 10%, depending on what you're treating, but you have to have a solution that makes sense. So, for example, if you're treating zone zero landing because of an aortic pathology. You have an arch that's at 30, and then you have a sorry an ascending at 30, and then you have an arch at 26, and then you have the descending at 32. I'm not gonna go over 34, 36-ish for the graph because I don't want to oversize too much in the arch where I'm gonna put my fenestrations and where I need exact measurements. So if the graft is all crimped up in the arch at the place where I have to be precise, I'm not really helping myself. And at the same time, I want to make sure that I have seals. So you want to make sure you oversize at least 1 to 2 millimeters, and that's the minimum. Usually, you want to oversize 4 millimeters ish, approximately, depending on the pathology. And you decrease that to 1 to 2 to 3 millimeters if you're treating dissections. That's a rule of thumb.
Thank you so much.
You're welcome.
So just looking at the time, I think we'll leave it at that and we'll get started with Dr. Moon's portion of the lecture. Thanks again, Dr. Fortin. I really appreciate it. And Dr. Moon, I should just ask before I introduce you, we've been recording the lecture just in case people want to review it in the future. Is that okay with you?
It's absolutely fine. I've been recording you the whole time.
Oh, Lord.
Yeah, no issues at all.
Perfect. Alrighty. So for our next talk, we have Dr. Moon presenting on open surgical management for thoracoabdominal aneurysms and type B dissections. Dr. Moon is the head of aortic surgery program at the University of Alberta. He completed his residency at the University of Manitoba and then completed a 2-year fellowship at Cleveland Clinic in aortic surgery and endovascular surgery. He's been practicing in Edmonton since 2014. So Dr. Moon, thank you so much for taking the time to teach us all today. The floor is all yours.
Okay, perfect. Thanks very much, everyone. I really enjoyed your talk, William. It was definitely the first few slides were kind of a snapshot of everyone I knew. I like to think I'm not that old, but I worked with Roy Greenberg and obviously overlapped with Tara and knew many of his fellows that he trained.
They're
So,
very nice people. I know
yeah,
I know a few of them, and it's amazing to see that they're so near us, and
yeah.
for us, the young generations, to see that it's just happened now.
Well, I'm glad that you use young generation, so I'll take advantage and say that you're talking about me as well. Thanks very much, Asher, for the opportunity just to speak with the trainees. This is something that I'm very passionate about, making sure that people have an opportunity to learn. And obviously, the topic of aortic surgery is what I'm very interested in. So I was tasked with the topic of thoracoabdominal aortic aneurysms and type B aortic dissections and the surgical approach. I thought this would be a pretty easy topic to do, but then I realized every talk that I had in the can was already on endovascular approach. So it was a little bit of a little bit more work than I expected. I do consult for Artivian. As you heard, I do have a lot of experience with the AMDS device. We're not going to talk too much about that. I think that could be a separate talk if you guys desire. And we do have a lot of experience in Edmonton with Jotech, the Vita Open Neo device. Just briefly, some outline objectives. Briefly cover the classification of thoracoabdominal aortic aneurysm, have an understanding of the diagnosis, the workup of this pathology, some indications, some surgical techniques, neuroprotection strategies, outcomes and surveillance, and just finish off with type B aortic dissection. You're going to hear a lot of very, very similar themes from the first, the talk that was given earlier. And it's because they're incredibly important. Just in brief, thoracoabdominal aortic aneurysm is any aortic aneurysm that involves both the thoracic and abdominal component. Often includes the visceral segment, and it's definitely associated with higher morbidity and mortality than aneurysms that are isolated to the ascending aorta, even the aortic arch or descending thoracic aorta. Etiology-wise, there's multiple different causes. Degenerative atherosclerosis. We do see patients with connective tissue disorders presenting with degeneration, and understanding their initial etiology does have importance in terms of trying to guide the intervention at the appropriate time. I think the most common thoracoabdominal aortic aneurysms that we are involved with seems to be a growing number of chronic dissections. I think with better follow-up, although I think it's still not perfect, and better medical management, we are allowing people to grow longer, meaning they've lived long enough, but they're presenting with pathology. And I do know that for our aortic rounds, our multidisciplinary rounds, we're definitely discussing a lot of patients that have had prior type A repair, and either type Bs with initial medical management, or those that had initial TVAR for complicated type Bs. And then there's inflammatory infectious causes. So the Crawford classification, there's 5 listed here, but there's 4 that we do have to focus most commonly on. Type 1 that are going from just beyond the left subclavian down to the diaphragm, or just by definition down to renal arteries, but most often these are involved or limited to the chest. Type 2 have the greatest level of aortic involvement. Type 3 just below the distal aorta down to distal thoracic aorta into the abdomen. And type 4, we don't see too many type 4s over at the Mazankowski or in the cardiac surgery realm, because the vascular surgeons are taking care of a lot of these on their own. We are doing an increasing number of extent 4s at the MAS combined with vascular surgery, where we feel that the patient would benefit from having cardiopulmonary bypass support. And there is the type 5. It's limited to the distal thoracic aorta and suprarenal abdominal aorta, and may or may not require selective visceral and renal reimplantation. As you heard before, the CT imaging is the mainstay of thoracoabdominal aortic aneurysm or aortic management overall. It allows us to assess the extent, which visceral branches are involved, and what type of access we have, whether it's for cardiopulmonary bypass, where are we going to put clamps on, or should these patients be potential candidates for endovascular intervention. As a cardiac surgeon that did do a lot of vascular or endovascular training, when I'm seeing a patient for a referral and it's referred with a thoracoabdominal aortic aneurysm, my ultimate goal is to make sure that I can do an assessment which would allow me to decide, is an endovascular procedure an option? And if so, what type of procedure would be offered? If I'm going to do a surgical approach, what is my surgical approach going to be? And then try and balance the risks and benefits of both of those for that individual patient that's right in front of me. So the exact same aortic anatomy may result in 2 different options, and that's going to be mostly based on what that person in front of me will be like their surgical candidacy, their comorbidities, and also balancing a truly informed conversation where we have informed consent and the patient can make and express what they feel their values are. And we always hear this concept of, you have to incorporate the patient values into the conversation. But if I, as a cardiac surgeon that could only do open, was talking to a patient, it would not be surprising if there was some underlying bias in terms of what I expressed to that patient. And similarly, if you were only a vascular surgeon that only did endovascular and did not have a relationship with good cardiac surgery colleagues, you would be telling information to the patient that would be in the biased opinion of, let's see if I can get this person to consent to an endovascular intervention. We have size criteria. I have a lot less slides on sizing, but generally we are looking above 60 millimeters when we're talking about thoracoabdominal aortic aneurysms. I think you can, in the right patient with excellent anatomy, low risk of endovascular complications, considered greater than 55. And we do look at smaller sizes. If we ever have concerns for increased risk of rupture or rapid growth. I agree with that point that Dr. Fortin had, where if a patient's growing 3 millimeters a year for 2 years, but they go from 41 to 47, I'm not sure. I wouldn't rush in and say, oh, this person has now rapid growth indication. Annual imaging is indicated when we are following these patients. I think that ultimately we are trying to balance the risk of unnecessary radiation and the trade-off of being able to make sure that we're not having unrecognized aortic growth. We have a lot of younger patients where they are receiving MR as the modality for imaging. When they are approaching a surgical cutoff, I do like to get CT imaging, even if they're young, because I think it does allow me to have the most fidelity, and in terms of trying to plan an endovascular procedure, having CT imaging with thin slice collimation is going to be incredibly important. There is this topic of acute aortic syndromes, which does involve the thoracoabdominal aorta, acute aortic dissections. We do know that there are patients that have extensive aortic involvement, but it's just intramedullary hematoma. Patients with penetrating atherosclerotic ulcers are driving their aneurysmal degeneration. And I do think that a lot of IMH are either, they're probably unrecognized, a lot of them are either going to be PAU or unrecognized type B with poor opacification of the false lumen or poor timing of CT scan contrast bolus. A lot of the radiologists will, cardiac surgeons and vascular surgeons say, oh, it's a thrombosed false lumen. I think the most correct way of stating that is that it's just a non-enhancing false lumen would be definitely more accurate, which would also allow it to be thrombosed, but would account for a poor timing, poor contrast bolus timing. And, this is just a slide of a patient that has an IMH involving both the descending and ascending aorta. And you can see an area of the PAU that is a likely source, whether that's going to be PAU or type B. It doesn't matter. Main thing is that they have pathology. And then the question is, how are you going to manage it? We're not going to be talking about management of the ascending aorta and the philosophical differences or practice differences in terms of timing of reimaging or emergent intervention. All patients, as we heard in the first talk, do require medical optimization prior to repair, strict blood pressure control and heart rate control. Statins, smoking cessation is incredibly important. Trying to optimize the patient both, and I'm supposed to say nutritionally and pulmonary status-wise. Having patients that are malnourished is not ideal. Having people with, emphysema or lung disease or exacerbations of asthma, not ideal. And also trying to see if we can optimize their cardiac function. We are referred a lot of patients that are obese. We didn't really talk about morbidly obese patients in the first talk, but because we do see some of these patients gradually reaching the point where they will need an intervention, I think it is our responsibility as physicians that are following these people to have that important conversation about weight loss and a referral to a bariatric clinic or the consideration as to why they're not on some sort of a weight loss drug. We do know that patients can lose a lot of weight very quickly, and ultimately that just makes a safer surgery. It makes it an easier surgery, and most importantly for the patient, makes it an easier recovery with less morbidity postoperatively. In patients that are quite young or presenting with quite young with aneurysms or degenerative disease or dissections, we always have to ask ourselves, are these patients having connective tissue disorders? Genetic counseling is recommended if we do identify a patient with a connective tissue disorder. In Edmonton, in northern Alberta, we do see people that will be young presenting with type A dissections, but not uncommonly in history, they'll be sharing that they're using cocaine as the reason for their hypertension. And it's, you look at them, they're not marfanoid in appearance. Yes, they're 30 years of age, but it was probably a cocaine-induced aortic dissection secondary to hypertension. A very important family history of acute aortic syndromes, family history of rupture dissections at sizes smaller than our guidelines are important to have. But having a mechanism for sharing the responsibility of these decisions to intervene, whether it's open or surgical, with a multidisciplinary team is incredibly important. Again, some slides on indications for size, typically greater than 60 millimeters, but in patients, I think, with low risk anatomy and very favorable anatomy for endovascular interventions, especially if it's limited to, you're not having full extent 2 coverage, where we're mitigating or balancing the risk of spinal cord injury, I do think that is reasonable to consider appropriate patients at 55 millimeters for repair. That's similar to what we heard in the first talk, rapid growth, 5 millimeters in a year or 2 years of 3 millimeters consecutively. Symptomatic aneurysms that have not reached size indications but have unexplained causes of pain that we cannot attribute to anything else, and patients that unfortunately are presenting with imminent or have ruptured or dissection. The guidelines are different between North America and the old 2014 guidelines and the new ESC guidelines, but I think the most important thing is individualizing our decisions for indications to the patient, their aortic anatomy, and having a conversation with multidisciplinary rounds. We review all, in Edmonton, we review bi-weekly with vascular surgery, cardiology, and cardiac surgery. I'm incredibly fortunate that I work with Matt Quinn, one of our vascular surgeons, who's a gifted endovascular surgeon. More important than that, he's a great colleague and incredibly conscientious about his approach to the patients. And just as I will regularly refer patients that, yes, I can operate on them, but I believe they'll be better managed with an endovascular intervention, the opposite also applies. Working with a vascular surgeon actually ends up with a lot more referrals for open surgical repair because Matt's a very conscientious human being. He can, I'm pretty certain he can stent almost any anatomy, but in his decision to do what's right for the patient, we'll have conversations on secure chat, texting, phone calls, where we're like, yes, this patient could have a stent graft, but this is the reason I think they should have open repair. We do talk offline, but we present the patients again at our multidisciplinary rounds because ultimately we want to make sure that we're not missing something. And sometimes things that are so common sense to an outsider, as a cardiac surgeon or vascular surgeon, we sometimes overlook this. So, by having that team discussion, we are making sure that we're doing best for our patients. Just in brackets here, it's incredibly important that you have favorable anatomy. Anytime you're decreasing your threshold for intervention, you don't want to be struggling, whether it's an open or endovascular case. So choosing open or endovascular, I do believe that an open repair is preferred in young patients and those with connective tissue diseases. As long as they're excellent surgical candidates, they have to have good preserved pulmonary function and have good preserved cardiac function. Some of the patients, I'll see patients that are 50 years of age with excellent, they look good, but they have, for whatever reason, bad lung disease or they have a bad cardiomyopathy. In some cases, open repair may not be ideal. Matt and I are just trying to schedule a young guy in his 30s for open surgical repair, it's going to be a hybrid case. We'll do a frozen elephant trunk because neither Dr. Quinn or myself feel that he should undergo an extent to open repair because he's close to 500 pounds. And then we're also concerned about connective tissue disorder. So for this patient, we're going to do a frozen elephant trunk from the top. Matt would do a limited laparotomy from the bottom, and then plan for an endovascular case, landing in Dacron, both proximally and distally, as you heard before, I think is an important consideration when we're trying to manage patients with suspected connective tissue disorders. Endovascular procedures are definitely considered for high-risk surgical candidates. More and more common, as you heard, hybrid approaches are very common. As cardiac surgeons, it's important we understand what our endovascular colleagues can and cannot do. And I do think that, yes, leaving a long length of ascending aorta is incredibly important. Not the focus of this talk, because we're not talking about aortic arch, but just a few days ago, we were talking at a meeting for some of the chief residents that debranching the innominate artery to allow for a single branch endo-arch option for arch pathology is something that as cardiac surgeons we have to ask ourselves, why am I not going to reimplant this innominate artery in a type A aortic dissection? Without a doubt, as you saw, I fully support isolated descending thoracic aortic pathology is the gold standard being endovascular. Similarly, blunt aortic injury, endovascular is the gold standard. My trainees know that when I talk about aortic surgery, it's all cerebral. 95% of surgery, I believe, is cerebral. If you're good, it should just be 5% hands, so your hand-eye coordination should be about 5%. You have to review imaging very carefully. You have to plan your proximal and distal clamp sites. But also you have to be thinking about your proximal and distal landing zones. Are they present? Is this something that maybe a patient should be better served with an endovascular intervention? You have to plan your visceral and renal protection strategy. So this is something that, every single case, whether it's a ascending aortic case, a descending thoracic aortic case, I still go through this whole concept of protecting the heart, the brain, and the body. And the body, it's typically the spinal cord and the viscera. When we are doing bypass surgery, we don't have to worry about protecting the viscera because we're perfusing the body continuously, but I still think about that when I'm envisioning a case. Most of the time should be spent planning. I can absolutely assure you I spend more time reviewing CT imaging and case planning with my trainees than the critical portion of a major aortic case. So if I'm doing a total arch, I'll have typically under 25 minutes of circ arrest for the distal anastomosis of a FET. The whole pump run will be less than 80 minutes, under less than 100 minutes. And in terms of when I reflect on how much time I've spent reviewing the case with my chief resident or my fellow, we'll spend more than that time discussing the case, not just the day before, not the day of, but leading up to that. And it's that time that you put in where you will get the results that your patients deserve. So preoperatively, you have to think about the cardiac risk assessment, pulmonary function evaluation, and then also with thoracoabdominal aortic interventions, what is the specific risk to the spinal cord these patients are going to be undergoing? So known risk factors, prior aortic replacement, infrarenal abdominal aortic work, whether it's open or endovascular, when the patients lose their collaterals, the lumbars, the internal iliacs, or the hypogastric vessels, we're subjecting the patient to a higher risk of spinal cord injury. Prolonged aortic cross-clamp times, the lack of distal perfusion if you're doing open interventions, the failure to reimplant critical intercostals or covering them with stent grafts can definitely impact that risk. And inadequate renal visceral protection. This is important because if we don't protect the viscera and the patients are ischemic, they have a lot of metabolites of ischemia, they will become more hemodynamically unstable. They'll have more fluid shifts, they'll have more edema, they'll be more difficult to manage postoperatively, and this hemodynamic instability will directly impact the spinal cord risk to the patients. So, the last two slides are, if you're thinking about intelligently how do you prepare for any exam, I think that these are going to be important slides to think about. But spinal cord blood supply, it's a classic question that you're asked in the operating theater. or in the office before surgery. There's a longitudinal artery system with the anterior spinal artery supplying the anterior 2/3. Motor function and spinal thalamic function is derived from this artery. Posteriorly, the posterior 1/3, there's two posterior spinal arteries supplying the posterior aspect. And then we also have the radicular and segmental arteries, the intercostals and lumbars, all of which help contribute to the blood flow. There is the artery of Adamowicz. Every now and then you can get the impression that you've identified it either intraoperatively or on CT imaging, typically located between T8 and L2. So this is a diagram off the internet. This is something that you should be familiar with, and you should be able to draw if someone were ever to ask you in the OR. Positioning, no different than positioning for just isolated left chest work. The only difference is we do make sure that the hips are at 30 degrees. I personally like the patient at 90 degrees if I'm getting into the belly. I think it helps kind of flip things over a little bit more anteriorly for the patient. But the hips at 30 degrees is important to allow for cannulation of the left femoral artery and the left femoral vein. Before you position the patient, when they're lying supine, I think it's very important that you mark where the femoral pulse is, where the inguinal ligament is going to be, the anterior superior iliac spine, the symphysis, abdominal midline, mark where the navel is going to be when they're lying. Right, mark the midline down to the navel when they're supine, because when you flip them over the side, it can be incredibly challenging. And it's also a very good reminder for the nursing staff of how far to prep down toward the bed when the patient's on their side. Similarly, I do like to mark where the scapula is, the costal margin, and also mark my actual incision where I'm going to be doing the thoracoabdominal aortic incision. Positioning of the arm, it's a little bit variable. Some have it directly over the head. Some people have the patient hugging the pillow. I like to use a bar with a spenco, a jowl, just to help support the arm and tape it in place. These are important things, and you should definitely have a roll to underneath the right axilla, an axillary roll to decrease the risk of nerve injury from a prolonged positioning during a long case. If you're dealing with an extent 1 thoracoabdominal aortic aneurysm, the vast majority of the time you can stay in the chest. For me, I decide if I'm going to go third or fourth intercostal space, depending on how much proximal work or how proximal into the aorta I'm going to need to be. You can always pull the diaphragm down. For those of you that have experience or have seen MIS surgery from the right chest, a lot of times most of the operators will put a stitch in the diaphragm and then pull that stitch through the skin with an endoclosed device and then actually pull down on the dome of the diaphragm. When you're doing extent 1 work, you can similarly pull the dome of the left hemidiaphragm down to the point where you can almost easily visualize the hiatus. And that, I think, is an important trick to do. So don't forget to do that. Same thing, like you would never not do it when doing a right thoracotomy. When you're doing left chest work, always pull the diaphragm down. It'll make your life easier. For 2, 3s, and 4s, thoracotomy through one of the lower intercostal spaces, you don't need to be as high because everything opens up that much more. Once you divide the costal margin to get down onto the abdomen, suddenly the ribs, the whole upper half is much more mobile, and you can easily see the left subclavian artery. Dividing the diaphragm, you have to remember that the diaphragm, the nerve supply to the diaphragm is radial. So I like to leave about a 1.5 inch rim of diaphragm circumferentially as I come anteriorly after I've taken down the hiatus. And it's important, unless you do enough of it, I think it's important to leave either ligoclips or sutures at matching points. So when you put it back together, it's done properly. The diaphragm will retract as soon as you divide it, and it's very easy to not sew it evenly. Definitely stay retroperitoneal at all cost. And when we are doing cases where we are taking down the diaphragm, I strongly recommend taking the diaphragm down, staying retroperitoneal prior to heparinization heparinization before you go on bypass. And even if I cool, I can take down the retroperitoneum quite quickly, so I don't think it adds too much time. But at the end of the case, the improved hemostasis, because you're not having this constant ooze because you've done the retroperitoneal dissection while fully heparinized, is definitely advantageous. So as surgeons, we need to think about proximal control, and no different than any endovascular surgeon, they're always going to think about their proximal landing zone, their distal landing zone. As surgeons, we need to think about what are we going to do proximally. And this will largely dictate whether you use left heart bypass or full cardiopulmonary bypass. And this is going to be surgeon-specific and site-specific. When I was a fellow at the Cleveland Clinic, I was trained with left heart bypass. My first couple of cases back in Winnipeg, I did use left heart bypass, but I switched to full cardiopulmonary bypass for reasons that I'll explain in the following slide. The other thing that you have to ask yourself is, are you going to be a surgeon that wants to do proximal anastomosis with a clamp on or with an open anastomosis? With open anastomosis, you have to have circ-arrest, but this does have important implications also based on how proximal you need to go, but also what your risk tolerance is for potential injury to the recurrent laryngeal nerve, or even getting into aortic pathology as you're trying to mobilize to get a clamp on. So again, you have to know how proximal you're going to be going. If I'm beyond the left subclavian artery and the pathology is mid-descending, I will put a clamp on, but I still will use full cardiopulmonary bypass. When I mean full bypass, I mean I have a reservoir, full heparinization, and cardiotomy suckers, but I don't need to be at full flows. So it's the best of both worlds, meaning I can use partial bypass, but I have all the tools that I need as a surgeon, and I can let the patient drift. I don't have to worry about this uncontrollable cooling of the patient. I can actively rewarm the patient as necessary. And other things to think about, don't ever get stuck into, I'm a left heart bypass surgeon and this is all I'm going to do, because the tissue is going to be incredibly variable, meaning you can have very robust tissue in aneurysmal disease, but if you're doing a post-coarctation repair or you're dealing with ductal tissue, it can be very fragile. And acute dissections, the last thing you want to do is start having the tissue fall apart proximally and not have all of your tools to start cooling to, you're not going to be able to salvage a case once you've gotten into a lot of trouble. Chronic dissection, I think a little bit more robust depending on acuity. So if you're subacute, it can be a little bit dodgy. But, people that have had aneurysmal degeneration of a dissection a year or longer prior, I think that you can expect the tissue quality to be quite safe to work with. Important question is, I like to sew circles. They're a lot easier than sewing ovals. So when you are doing open anastomoses, the anastomosis on the left will take actually less time to do than the one on the clamp in almost all cases. For those of you that don't believe me, I can look at how long it takes my own trainees to sew. All of my trainees can do an open anastomosis, whether it's a hemiarch or from the left chest, much quicker than they can do it if we have a clamp on. And also, it's more hemostatic. I think there's less ripping and tearing of the tissue, especially posteriorly, and your suture placement is much more accurate. A lot of the fear of using circ-arrest is surgeons that don't do a lot of aortic surgery. So they're typically sewing with the clamp on. They're dealing with the complications we just discussed of sewing with the clamp on. And then they add in their mind, oh my gosh, how bad is this going to be if I add hypothermia and we're going to get platelet dysfunction? How much worse it's going to be? They don't realize it's actually going to be quicker and more hemostatic if they can do it with an open anastomosis. So cardiopulmonary bypass, just briefly, on the left-hand side, we have left heart bypass, and then cardiopulmonary bypass on the right, whether it's full or partial. There's a difference in heparinization. Less heparin is required for left heart bypass, but you don't have a reservoir, you have no cardiotomy suckers, and you absolutely must be able to return massive amounts of volume back to the patient. What I mean by this is you clamp the aorta between the carotid subclavian, and you're going to open an extent to thoracoabdominal aortic aneurysm. You're going to spill 1,500 cc's of blood into the chest as soon as you open up that aneurysm. And it's not because you spilt it, that's how much blood was in the aorta. And if you can't give that volume back, you're suddenly going to have a patient that's going to be potentially quite unstable. And are you going to use a cell saver? Are they going to spin the blood down? In Cleveland, we used a cell saver, but we didn't spin the blood. We ran right off the bottom quarter-inch tubing into a roller pump that went right back to a subclavian venous line to the patient, where essentially whatever was collected in the cell saver, the anesthetist would control the pump. They'd look over and say, okay, you got 500, 600 cc's in there. They'd turn the pump on and just run it down to the bottom. Just above, there's no alarm, so they have to pay attention. But they could immediately give that volume back. But if your patient's starting to cool, drift in temperature, you have no ability to rewarm that patient. But in almost all cases, you're clamping proximally. If you're doing work that's just beyond the left subclavian artery, you will be clamping between the carotid and subclavian in many cases, and you will definitely be having a much higher incidence of left recurrent laryngeal nerve injury. With full cardiopulmonary bypass, yes, you are fully heparinized. You have the reservoir. You have cardiotomy suckers. You can give back volume very rapidly, and you can also help manage or control the patient's temperature, both for active drifting, active cooling if you're going to use circ arrest with an open anastomosis, but you can also rewarm a patient. So if I'm doing partial bypass with the clamp on and the temperature is dropping, it's very easy at the end of the case just to, as you're finishing up, to start warming up the patient back to 35 and a half, 36 degrees, and that patient is going to be much easier to manage in the ICU. Visceral perfusion strategy is very important. Selective perfusion of the celiac, SMA, and renal arteries is something that we need to consider. Specifically with the renal arteries, you can use renoplegia, Ringer's lactate plus mannitol plus minus some sort of steroid of your choice. Some centers will use custodial. Typically, this is near ice cold temperatures, but 4 to 10 degrees is very commonly reported. If you're giving a bolus 200 to 300 cc's to the kidney, it does a few things. It induces hypothermia, decreasing the metabolic rate, but regular intervals of 20-minute boluses, it does help out wash some metabolites of ischemia and can, in theory, reduce injury to the kidneys because of these free oxygen radicals that are present. Some people like to use continuous low-rate infusion as another option. And again, this is philosophical, depends on how you're trained. As a fellow, I was trained to use renoplegia. We would bolus the kidneys at the beginning of the case. If we felt it was going to take longer than 20, 30 minutes to get to the next restoration of renal flow, we'd bolus again. I now, if I'm going to do that, I actually use cold blood, moderate temperature blood, 28 degrees. I just run it off the cardioplegia circuit. Left chest work, I'm letting the heart fibrillate if we're doing fibrillation. And if we're going to stop the heart. But I'll run blood at 28 degrees, both to the kidney and viscera. Why? Because that's what we run to the brain. That's what the body's getting normally. And, it's going to be something that is going to be physiologic. Very important, minimize ischemic time. So the reimplantations, it can vary. If you can do an island or a patch, I definitely recommend doing that. It's a quick, simple way to deal with 1, 2, 3, or 4 of the viscera. So if you're coming from the chest and you're stopping just at the suprarenal segment, you can choose to put the SMA and celiac on as branches, or if you bevel your anastomosis, you can include those. So depending on the pathology that you're dealing with, will determine whether or not you can bevel your distal anastomosis to include one or all of the visceral vessels. If you are actually crossing the visceral segment, you can use an island technique. Again, that's something that I'll base on directly looking at how much thrombus there is, how much atheroma there is, and if there's any visceral artery stenosis. If there's visceral artery stenosis, I think it's important to just use a branch. When I started my practice, we did not have the Caselli graft available, but now it's available, I think, across the country. So it has definitely revolutionized and made an extent to much, much quicker. So, just some examples. On the right-hand side, they are using a branched, a graft that does not actually have 4 individual branches, but they're using a shunt to the SMA, and they're running cold blood or cold solution renoplegia to the kidneys. But it comes down to whatever you think is going to be the easiest is what you should be doing, and there's no one way for everything. I'm not going to tell people what I do is the best. It's just what I happen to do. But if you think that you can hey, I can easily sew this as an island or a patch. Do what you think is going to be easiest. When surgery is easy, it is reproducible. And that's a very, very important point. The middle panel here is just showing left heart bypass, and off the return to the lower body, they just have a multi-perfuser allowing for a visceral perfusion to the lower body. I prefer to clamp as much as possible, meaning for my proximal anastomosis, assuming there's no massive thrombus burden, I will clamp the mid-thoracic aorta and continue to perfuse the lower body and all the viscera while I do my proximal anastomosis, even if it's done open. So if I have a clamp on, then the heart's beating, the brain's getting blood the whole time. I'll do my proximal anastomosis, but I will still perfuse the lower body and the viscera. When I'm getting to the visceral segment, I will place a clamp in the infrarenal area and now perfuse the lower body, hopefully get both internal iliac arteries or the hypogastrics, get upper body perfusion from the heart, and then give selective visceral blood flow to the viscera as I do them one by one. I like to do the left renal artery first because it's the right renal artery because it's the most difficult to get to. But once that's done, I do my cases with either vascular or Dr. MacArthur, my other aortic colleague. We'll sometimes just do the distal anastomosis to allow the heart to pump blood to the whole body, and then do the left kidney and the SMA celiac last. Some people advocate doing these first before you get your distal anastomosis, and that's going to be a judgment call based on your exposure, how long you anticipate the body to be without flow. If I'm having to clamp the left common iliac, so my lower body perfusion is only going to be going to the left internal iliac, I would then aim or put a priority on establishing bilateral lower extremity flow, because I think that is important in mitigating or decreasing the risk of spinal cord injury. So there's no one formula for how you do this. You have to use common sense and make conscientious decisions based on the patient's anatomy and the situation right in front of you. As surgeons, spinal cord protection is incredibly important, so we have to maintain the perfusion pressure, reattach intercostal arteries when possible. If the artery is back bleeding vigorously, I just oversew it. I don't reattach those ones. I'm concerned about the ones that are not back bleeding, especially large pairs that are not back bleeding. I think that is very important. With open surgery, I do prefer to have a CSF drain in ahead of time, which is a little bit different than what you heard Dr. Fortin talk about, being reactive and putting it in. And that's largely because there's a higher likelihood of having coagulopathy post an open repair than you will with an endovascular repair. And it's going to be very challenging to get your anesthetist to be able to put a CSF drain in that patient in that situation. And if that's what they require, I don't want to deny that to the patient. Secondly, in an open repair, it's very rare that we can extubate or have the patient awake at the end of the case to do a neurologic assessment. And not knowing what's going on you don't want to wait 6 hours or 12 hours before you realize the patient is actually having a compromised spinal cord. Distal perfusion, as I said, maintaining distal perfusion either continuously or as long as possible is incredibly important in spinal cord protection. Minimizing blood loss and transfusion requirements is important. Minimizing hypotension or wild swings in blood pressure is important. Avoiding hypothermia, and when indicated, a CSF drain. If I'm not going below T6, I will not put a CSF drain in. If I'm going right down to the diaphragm, I don't routinely, but I will ask myself, is there anything in particular about this patient that makes me want to put a CSF drain? Any infrarenal or any abdominal aortic work, absolutely. If they have an absent or an occluded internal iliac artery or arteries, they also will get a CSF drain. So left heart bypass allows you to maintain distal perfusion. It reduces proximal hypertension and potentially endocrine ischemia. Neuromonitoring, for extent 2s, we will use it. It becomes a little bit less of value when you circ arrest a patient because the nervous system doesn't conduct properly. But I do like it at the end of the case because it will guide me as to what my target blood pressure is. It does not prevent spinal cord injury, but it helps guide it. So meaning my neurophysiologist can very accurately tell me that above 65, the spinal cord is completely intact. I like that information. Or if they say above 60 millimeters of mercury a map, your blood pressure is totally fine, so your spinal cord is fine, then I can tell my ICU doctor, I don't tell them keep it at 60, I say just aim for a map of 70 to 75. So we have a buffer where we know. How do we know it? Because if you let your pressure drop on purpose, you will see very, very rapidly and consistently a change in your spinal cord, the somatosensory motor evoked potentials. And then you just raise it up again, and then you can have a good sense of what your target pressure should be during the case. Also, only once, so once in 20 years, have I had to reimplant a spinal cord pair of intercostals that has actually improved spinal cord function, meaning I'm being told that, hey, we don't have motor evoked potentials, we've lost them. And I see a big artery that I'm contemplating oversewing. I just started reimplanting pairs after pairs, and suddenly they're like, hey, everything's back to normal. Well, in that case, that particular patient, even though they're having back bleeding intercostals, it was insufficient to perfuse their spinal cord. So I do like in my open repairs, Extent 2s to do use neuromonitoring, and even for the Extent 4s. Pathology just in the chest, I will not use neuromonitoring, but it's what you do with that information. If you're not going to react to your physiologist telling you that you're losing your evoked potentials, you're not going to bump up the pressure, or you're not going to start reimplanting intercostals, then I don't think it's of any value, because you're not using that advantage, that information to your advantage or the patient's advantage. Bleeding and coagulopathy, absolutely you need a cell saver. You have to have a plan for massive transfusion protocols. I think what's really changed over the last 10 years is targeted resuscitation of the clotting system. Having a ROTEM done where you can actually see that the platelet function is not the issue. This patient needs more fibrinogen. You can't overstate meticulous hemostasis, and I always talk about the P's of hemostasis. So there's a big pile, proline, plaget, pericardial patch or patching protamine, platelets, plasma, PCC, powder, whether you use Arista powder or snow, plasminogen inhibitors, pressure patients, packing, plugging, put your finger on the hole and fix it. But none of that will be a replacement for planning, preparation, prevention, and being purposeful with your actions, your surgical motions, and your surgical decisions. So, these are important things that it's a repeat of what you heard the first talk. It's all cerebral, it's all planning, it's knowing what you're going to do before you get there. In ICU, the best surgical procedure, whether it's open endo, can be undone by your ICU. You have to maintain maps. I've had patients have spinal cord injury because the nurse didn't want to wake up the patient to do the neurochecks because they thought the patient was very tired. That's non-negotiable. You have to have early hour checks. I've had patients lose spinal cord or have impaired spinal cord function at 5 in the morning, 3 in the morning. This is a surgical emergency. No different than suddenly having a patient dump 500 cc's of blood. Losing spinal cord function is incredibly important. And that same panic that they have with, dumping 500 cc's into the chest tubes, they should be panicked that, the patient's not moving their feet or toes. Monitoring renal and visceral organ perfusion is also important because sometimes branches can go down. They can have thrombus, embolism go down into one of the branch vessels as well. So it's important to follow that. And dealing with complications, spinal cord ischemia, paraplegia is incredibly important. If the drain's been taken out, you have to put it back in. And this is something that I've had to do in Winnipeg and in Edmonton. Delayed spinal cord ischemia, I think in almost all cases can be rescued. So you have to be very, very aggressive with that. You can't let the patient become metabolically disturbed too much. So managing renal failure early, I think, is important. Respiratory failure, having a hypoxic patient is not ideal, and having ongoing bleeding. Going back to the operating theater sooner rather than later is important. But I don't mind hypertension, even though it's having ongoing bleeding. Lars Svensson always said there's a blood bank. Every hospital has a blood bank, but no hospital has a spinal cord bank. So you have to be quite aggressive about correcting coagulopathy, maintaining good hemoglobin levels, and maintaining good oxygenation of the patient. If I know a patient has borderline spinal cord function and we're trying to rescue them, my target is a hemoglobin over 100. And you will always hear from the intensivist, well, that's not the guidelines recommend. The patient's, 50 years old, so they can tolerate a hemoglobin of 80. My response is you can explain to them why they're paraplegic and you wanted a hemoglobin of 80 instead of 100. Like at that point, I want a hemoglobin of 100 because that oxygen carrying capacity, delivering oxygen to the spinal cord is important. Same thing with respiratory failure, aggressive diuresis of edematous lungs, 100% FiO2, making sure that you're not leaving a patient with a borderline PaO2, which might be okay if they're not paralyzed, but when you have a patient with a spinal cord injury, you can't tolerate a PaO2 of 100 because they have very little buffer. So again, things that seem common sense or normal don't apply when the patient has a spinal cord injury, because if you don't rescue it, it's a very devastating complication. The spinal cord injury patients, they always come to your clinic. They always show up in their wheelchair to remind you how they ruined their life. They're very, very different than stroke patients. Stroke patients, they've neglect. It's quite protective. And they're upset, but they're never as upset as their families. But the patient that has a spinal cord injury, they're upset at you themselves in addition to their family. Operative mortality, depending on the literature, Coselli's group out of Texas, they report some of the lowest numbers for mortality in paraplegia and stroke in the world. They're probably some of the highest volume centers, but it's accepted that the range mortality is between 5 to 15%, largely dependent on how much aorta you're replacing. Similarly, paraplegia risk is 3 to 15%. The extent 2s have the highest mortality complication and the highest rate of paraplegia. Renal failure is also a very common complication, but in almost all cases, patients just need temporary either CRRT or a short run of hemodialysis, and renal failure, renal function does recover in most patients, fortunately. Surveillance, I like to get early CTs at 3, 6, and 12 months, and thereafter annually. I think it's important to monitor anastomotic sites, especially if you are questioning the quality of your tissue that you're sewing to. A lot of these patients have dissections, and we're not fixing them all at once, meaning we're just, for example, just doing extent 1 work, and they still will need their annual imaging for the remainder of their aorta on an annual basis. People do talk about the risks of lifelong radiation-induced or increased risks of cancer, but it's also important that many of these people will not have a normal lifespan because of the disease process that brought them to the operating theater. So in summary, it's a complex procedure requiring multidisciplinary planning. Neuroprotection, organ perfusion are key. Outcomes improving the experience and adjuncts. Just a few slides here. Ultimately, for type B dissections, we're only interested in the complicated cases. Both get optimal medical therapy, but the ones that we're intervening on are going to be the complicated cases. If it's chronic, then it's no different than the aneurysmal degeneration that we talked about in the first section. So patients that, despite OMT, optimal medical therapy, that are hypertensive, having ongoing pain, evidence of malperfusion, imminent rupture, or they've ruptured, they need something done. The gold standard is still TEVAR. It's only a handful of times have I gone to the operating theater for left chest work for type B dissections. I think 3 times. Surgery and TEVAR, I should say, and TEVAR, is limited to when TEVAR you don't have a landing zone, meaning you have arch involvement. You either have a dominant left foot coming off the arch. There's ascending aortic involvement, which is a B0 dissection or a type B with retrograde, or the ascending aorta is pathologic, meaning it's 55 millimeters, 45 millimeters, something that the endovascular surgeons can be concerned about its appearance. As I said, dominant vert, incomplete circle, you're not going to want to cover that recklessly without doing some sort of either interposition or transposition of that dominant vert, the left vert. Absence of vascular access is also a reason that surgery is considered over TEVAR. Patients with known connective tissue disorders and chronic dissections. Some of the anatomy and specific chronic dissections may not be favorable for TEVAR. And the extent 2s that we are still doing open almost all of them are endovascular, fortunately, are the ones that have anatomy that is not amenable to an intervention, and it's going to be limited by the lack of proximal landing zone due to chronic dissection. So goals of surgery are to resect the entry tear, restore blood into the true lumen, and resect the area of the aorta that's at risk of rupture if present, similar to the Knickerbocker technique that there was a slide on, which also had the slide showing the candy plug. We're primarily concerned about the thoracic aorta rupturing in the early period following type B dissections. But I have this slide here for this or that. Like, do you actually need to resect the primary entry tear? In TEVAR, we cover it, and the goal is to prevent flow into the false lumen through the primary entry tear, but there's still false lumen flow at the visceral level. Sometimes it's significantly decreased because you've not adequately covered the primary entry tear with your TEVAR. You will see that. But a lot of these patients will have retrograde flow from the visceral segment. So, I always ask myself, are we preventing all flow through the primary entry tear, or are we just trying to reduce it? So I posit this question, and it's supposed to be provocative. Are we supposed to resect the entry tear or reduce flow through the primary entry tear? Like, we have to restore blood flow to the true lumen to address malperfusion. But with this first line, it then can make the surgical approach a little bit different, or it gives you some options. And then understanding what the risks of the surgical procedure are. Anytime we do open surgical surgery, we can deal with bleeding and bad exposure, dealing with poor quality tissue, which was always the case, whether it's type A or type B dissection. We have to protect the brain, protect the heart, protect the body, and that's what I said in the first portion of the talk. So left thoracotomy approach, very common approach, but we don't do it often, fortunately. You're often sewing to poor quality tissue. Bleeding is a reality. Exposure can be quite challenging. Hypothermic circulatory arrest, deep hypothermic circulatory arrest, plus minus ACP. You often can't get into the left common carotid artery, so it's true circ arrest, no ACP. The heart is fibrillating. It's hypothermic. It's safe. And the body, if you can clamp the lower distal thoracic aorta and perfuse the lower body, you may have some perfusion, but often it's done with circ arrest. Compared to sternotomy approaches, this is, keeping in mind, I'm thinking about a frozen elephant trunk in here. You can still sew to bad tissue, especially if you have zone 2 involvement. If the ascending in zone 0 is involved, we have to go through the sternotomy. It's a B0. But if you're dealing in the arch, usually the tissue is not as bad if it's not involved. We can always give ACP, almost always, but I think you can, and you're not cooling as much. We're protecting the heart with cardioplegia, so it's way better protection. And again, we're not using temps of 18 to 20 to protect the lower body, but we still have hypothermic circulatory arrest for the duration of the distal anastomosis, which is typically less than 30 minutes for most surgeons. So in 2020, I thought this was very recent, but I didn't realize 5 years had passed. SVS, SCTS, they have reporting standards for type B aortic dissections. You should all be familiar with these slides. On the left is going to be zone 0, just under the nominant artery, but this is a type A aortic dissection. This would be a type A9 ending in zone 9. These are the exact same zones that you saw in Dr. Fortin's talk. The middle one is a type B dissection with retrograde extension. This patient here, in my mind, would be the ideal candidate for frozen elephant trunk, with the goal to direct blood flow into the true lumen and cover either completely or significantly reduce flow into the false lumen. Your early post-op imaging will guide you in terms of whether or not you need to do an early TEVAR at the same hospital admission. And the non-A, non-B, this would be also a patient that should be treated. If the anatomy extends proximally with a pathology, then this should also be a frozen elephant trunk. But I do think that now, with the fact that we have frozen elephant trunk on the shelf, I would much rather, unless they've ruptured, treat type B malperfusion with this middle scenario and frozen elephant trunk. As surgeons, you are increasing the risk of the stroke risk to the patient because we're manipulating the carotids, but I do think that is almost a wash when you think about the protective aspect of integrated cerebral perfusion. There are devices on the shelves of some hospitals that are essentially just a frozen elephant trunk, meaning I guess you would just transect in zone 2, drop a frozen elephant trunk, suture it in place, and then sew it the aorta back up if the proximal aorta is not involved. I actually think that's safer than going through the left chest because we can give ACP and we're not as cold. So I think that it's going to be more secure in anastomosis. And then my first 15 years of my life, we're doing conventional elephant trunk and TVAR. This is something that we did on a regular basis, but we would immediately do TVAR at the same setting or going from the operating theater to the hybrid room, because the conventional elephant trunk in of itself would have less impact on mitigating flow through the primary elephant trunk, the primary entry tear. Very commonly what we've heard, combined approach is important. So sometimes carotid subclavian bypass is required. You have to manage abdominal effort. The dissected aortic arch with no ascending aortic involvement, I think, is a great situation where cardiac surgeons can work with vascular surgeons to do some form of a TAR FET. And ultimately, what you heard Dr. Fortin asking us to do as heart surgeons is create a proximal landing zone, especially if the pathology is in zone 3 and zone 4. Thanks very much.
Fantastic. Thank you so much, Dr. Moon. That was great. We have a decent amount of time right now, so if anybody has some questions, again, feel free to either speak up or you can write it in the chat and I'll read it out. I'll give us a few minutes if anybody has something to ask.
I have a question for Dr. Moon. Thank you so much, Dr. Moon. This was so instructive. In one of your slides, you mentioned that when you do descending or thoracoabdominal aorta surgery for the proximal anastomosis, you like to do it open or clamped. In the case of open, you go into deep hypocirculatory arrest for that, I assume. But my question is, in like one of your last few slides, you mentioned with the left thoracotomy approach, you could do plus minus ACP as well. How do you set up for that if the patient is in left lateral decubitus?
Yeah, that's a very good question. So in that situation, you are limited, or you're almost limited to only being able to access the left common carotid artery. So when I'm working from the left chest, whether it's a thoracoabdominal aortic aneurysm or thoracotomy, so I'm just sticking to the left chest, I will Y my arterial line always. And that will allow me to, once I finish my proximal anastomosis, if I need to, if I've used complete circ arrest and I need to start reperfusing proximally through a side limb, I can recannulate the side limb and now deliver blood to the heart and the brain, and then continually perfuse the lower body through the femoral artery. With left chest work on this side here, if I'm using ACP, we're not using cardioplegia. So off of the cardioplegia circuit, I make sure they're not hanging any cardioplegia. But then I use the cardioplegia circuit, the pump head for that, to deliver my ACP. And if I'm going, I would selectively go up the left common carotid artery. If it's dissected tissue, I personally am not too keen about putting a catheter blindly into the left common carotid artery, even though I think it should be relatively safe. I don't like to put a Gundry up there and have that inflate, because I'm worried about creating a new injury in that left common carotid artery. But I can run that off the cardioplegia circuit. Once we finish the proximal anastomosis, I can then also use that same circuit with a multiperfuser or an octopus to perfuse the viscera. So all my adjunctive flow, whether it's the brain or the viscera, is going to come off the cardioplegia circuit. And at the minimum, even if I'm not going to use it, I like to make a Y in my arterial line for aortic cases.
Thank you so much.
I think, sorry, go on.
Oh, no, I was just going to say if we have any other questions or comments.
I just wanted to say great talk, Dr. Moon. It's amazing to see the expertise and everything that you guys do. It always amazes me the amount of techniques that can be done for these kind of very complex surgeries.
Yeah. I think that for the residents, the trainees, uh, what you need to appreciate is that a vascular surgeon like Dr. Fortin is not just a vascular surgeon. He's a surgeon that has a very strong understanding of the cardiac surgery aspect because he will work with the cardiac surgeons. Similarly, a lot of what I know is, yes, I spent a year at the Cleveland Clinic in the vascular department, which was a huge part of giving me what I needed to know. Early in my practice, I was doing fenestrated and branched extent twos. Now we have Mac Quinn, so I don't have to do any of that. But still working with a vascular surgeon allows you to know what you can at least offer your patient. And the struggle we all have is we don't know what we don't know. And that's why you need, in this space, in this aortic space, to work with vascular surgeons that are open-minded and wanting to work together, but also making sure that your anesthetist is good as you are, your perfusionist, because like the weak link will undo the best plan. And it means having that conversation with your perfusionist to have them understand, I'm not asking you, I'm on partial bypass. I'm not needing you to go 5 liters a minute. But some of them do. Like, it's amazing. Some of the junior perfusionists will run 5 liters a minute. And I'm like, no, just run a liter per minute because I'm just trying to perfuse the lower body. But they don't understand. They've emptied the patient. You look over, patient's got a systolic of 40, but the reservoir's got 3 liters of blood in it, and they're running 1 liter a minute. Like, I'm not asking you to drain that patient. But if you don't know that as a surgeon, your perfusions will kill your patient. Absolutely. Same thing in ICU. You can have the best perfusionist, anesthetist, vascular surgeon, heart surgeon, nurses. Drop the patient off in ICU. ICU can kill your patient in 6 hours. So, it's not that they're not good. They can be excellent, but they just don't even know what you don't know. So that's why you have to be hovering around. You have to always be making sure that you're keeping an eye on what they're doing and, finding ways of communicating to them that they don't know what they're doing without saying that. But, it's something that it's a huge growth, pardon the pun, it's a huge growth area still in both aortic, cardiac, and vascular surgery. It's something where in the United States, I was just, Devin and I were just at a meeting on the weekend where, every center is looking to hire aortic surgeons. And they're not just needing one, they need 2 or 3 because there's that much work continuing to grow. Yes, the coronary disease space is increasing again. Yes, surgeons are cross-trained in transcatheter, so they're picking up some of that lost aortic stenosis volume. But the aortic disease volume is growing incredibly fast. And if you're not going to be a specialist, you still need to understand what you don't know so you can make sure that the right person is involved in your patient's care.
All great points. Thank you so much, Dr. Moon. I'll give us maybe one more minute in case anybody has any questions. If not, I believe that's the end of this session, unless you guys had some specific cases that you wanted to discuss with us. But looking at the time, I'm not sure we're really going to be able to do too much of that.
Yeah. Do you want us, do you want me to, or Asher, do you want them emailed to you, the talk emailed to you?
If you can, that would be fantastic. I've also recorded everything, so it will be up for everybody to see, usually within about 2 weeks.
Okay.
So if people want to, but yeah, if you want to email it to me, that would be fantastic as well, and I can distribute it amongst the program directors.
No, not a problem. I can email. I've corrected all my spelling errors. You have recorded them, unfortunately, but I've corrected them. So if people want the talk, you can just feel free to distribute that to whoever wants. And for anyone else that has questions that they think of later on, please email. I know I speak for Dr. Fortin. Just email us or reach out to us because we're here for you guys. We're here for the trainees. We want to make sure that you get the most out of this session as possible. But thank you for the opportunity to be involved, Asher.
Same. Thank you.
Absolutely. Thank you both very, very much. I'm also just going to leave my email at the bottom in case anybody has any suggestions for future sessions. We're thinking of incorporating pediatrics into either our next session or the session after, but if anybody has any suggestions, I'm certainly open to it. So I'm just adding my email right now. And otherwise, you are free to go. Thank you so much, everyone. And thank you so much again, Dr. Fortin and Dr. Moon.
Okay, perfect.
Yeah.
I'll send it to you right now, Asher. All right?
Awesome. Thanks a bunch.
Thanks,
Have a
Mark.
great evening,
Yeah,
guys.
pleasure. Have a great day, everyone. Thanks, guys.
Thank you, professors. Yeah,
Asher,
incredible.
Asher, where can I find the recorded lectures? Is it under the resources at CSCS?
Usually they're posted under the, or here, let me just